Today we will be discussing about pathophysiology of jaundice, pathophysiology of jaundice. How do you define jaundice? Yes, please. What's your concept of jaundice? It's a yellow discoloration of eyes. For example, if someone is taking lot of carrots and lot of beta carotene has gone to the body and some tissue turns yellow, is that jaundice? That is not jaundice. Just increase in bilirubin level is not jaundice, because sometimes bilirubin level goes slightly above the normal level and we say there is hyperbilirubinemia, but if it does not impart the yellow color in skin or mucous membrane or interstitial fluid or sclera, we don't call that jaundice. So I think before you tell me new definitions, I must tell you what is jaundice. There are three terms which you should be clear. Number one, jaundice. Another term is hyperbilirubinemia. Then there is jaundice. Then there is another term is icterus. Then another term is cholestasis. These are terms which should be differentiated from each other. First of all, we must know that bilirubin is produced mainly during the breakdown of RBCs and other hemoproteins, and bilirubin is highly toxic molecule. And because bilirubin is constantly being produced in our body, whenever RBCs are breaking down and whenever hemoproteins are breaking down, these toxic molecules, because they are daily produced about 0.2 to 0.3 grams per day, so this bilirubin should be pushed out of the body. Body should have very, very efficient mechanism to get rid of bilirubin. But if bilirubin levels go above normal in the body, first of all you should know what is the normal level of bilirubin. What is the normal level of bilirubin? Yeah, 0.2 to some people 1.2 milligram per dl. Some people take it up to 1.6. Anyway, if we say this is the normal level of bilirubin, 0.2 to 1.2 milligram per dl, right? And if your level go above that, we say there is hyperbilirubinemia. So how do we define hyperbilirubinemia? That bilirubin level in the body is more than normal levels. Is that right? Now, actually what really happens, look here, this is normal bilirubin level range, right? 0.2 to 1.2. If someone bilirubin level goes up to this level, is not going to develop yellow coloration of skin or sclera or the mucous membrane or interstitial fluid. Actually, significant concentration of bilirubin should be there, so that enough yellow coloration of the body tissues occur, so that it can be appreciated by the eyes of the examiner. Usually it happens when bilirubin level is somewhere around 2.5 milligram per dl. When bilirubin level, when it is going up, when it reaches around 2.5 milligram per dl, then what really happens, that observer can identify the presence of high bilirubin level. Is that right? And how the observer decides? Because patient shows that there is yellow coloration of or discoloration of the skin and mucous membranes and sclera. And when you have especially skin and mucous membrane with yellow coloration due to hyperbilirubinemia, we call the condition jaundice. So what is jaundice? Jaundice is yellow discoloration of the skin, mucous membrane and interstitial fluids, right, due to, and sclera, due to hyperbilirubinemia. Right? It means every hyperbilirubinemia is not jaundice. Very mild hyperbilirubinemia is not jaundice, right? Hyperbilirubinemia should be up to a level that observing people are able to, you can say, appreciate the yellow coloration of the skin or the mucous membrane or the sclera or the interstitial fluid, then we say jaundice is there. Is that right? Another important thing is, what is icterus? Icterus is the term which is used when, especially due to hyperbilirubinemia, sclera turns yellow. When we say, I can detect the icterus in this patient, it means the person is specifically referring to yellow discoloration of sclera. Is that right? Again, what is icterus? Icterus is yellow coloration of sclera due to hyperbilirubinemia. Remember that sclera shows the yellow coloration very easily as compared to the rest of the body tissues. The reason being, number one, sclera is white, so faint yellow color can be appreciated. Secondly, it's a scleral certain connective tissue molecules, they love to bind the bilirubin. Due to these two reasons, what really happens, that icterus is usually appreciable before the full-blown jaundice develops all over the body. If you are really watching your patient, you can say examining your patient serially, right? Again, I will repeat. What is hyperbilirubinemia? When your bilirubin level is more than normal. What is jaundice? When hyperbilirubinemia leads to yellow coloration of skin, mucous membrane, sclera, and interstitial fluids. Right? What is icterus? When we are specifically referring to yellow coloration of sclera due to hyperbilirubinemia. Due to hyperbilirubinemia. Because if there is yellow coloration of body tissue due to some other reason, that should not be considered jaundice. Then another thing which is there is what is cholestasis. Yes. Have you heard of this term? Cholestasis? What is cholestasis? Yes, please. Dr. Kashif, what is cholestasis?
When bile flow stops.
Right, he is very right. Actually, what he is talking about, that there is impaired bile outflow. Right? He is right. Under these circumstances, not only bilirubin spills over into blood, but other content of bile may also spill into blood. You know, bile has many contents, but three most important contents of the bile you should never forget. And what are those? Three most important contents of the bile. There is bilirubin, the bile acids or salt, right? And what is the third component of it? Yes, please. Cholesterol. Right? Now, when we say this hyperbilirubinemia, it means we are specifically talking about increased concentration of bilirubin. We are not commenting on level of cholesterol or level of bile acids or bile salt. But sometimes it happens that bile outflow from hepatocytes or from the bile ducts stops, right? And all these substances regurgitate into blood. So, if someone has raised level of bilirubin, along with that bile salts and acids, and along with that cholesterol, all of these substances are raised into blood, then we say person is suffering with cholestasis. What is cholestasis? Cholestasis is that there is impairment of bile outflow. Of course, you know, bile is formed from the hepatocytes and thrown into intrahepatic biliary canalicular, and from there it goes to the extrahepatic biliary drainage system. You must be knowing there is right hepatic duct and there is left hepatic duct. They fuse together to make common hepatic duct. Then there is gallbladder cystic duct, and then there is common bile duct, which fuses with the pancreatic duct in most of the patient. Is that right? And opens at the duodenum at ampulla of Vater. Is that right? Now, if there is problem with that system, let me draw the diagram. Let's suppose that here is your liver, right? Hypothetically, if these are your hepatocytes and these are biliary canalicular system, these are biliary canalicular system, Of course, you must be knowing that here is your yes pancreas. Now what really we see there? What we really see there, right? These are considered this point number 1. Intrahepatic biliary canaliculi. Point number 1 is intrahepatic biliary canaliculi, right? Then, of course, you can say from both sides, this is right hepatic duct, and what is it? Left hepatic duct. And right and left hepatic duct, they fuse together to make what? Common hepatic duct. And what is this fusing with the common hepatic duct? Cystic duct. And then common hepatic duct and cystic duct, when they fuse together, they make, what is this? Common bile duct. And common bile duct fuses with which other duct? Pancreatic duct. So pancreatic juices and bile both can come out from this particular orifice. What is this? Ample of Vater, and surrounded by sphincter of Oddi. This is called bile outflow system, right? If there is obstruction with this bile outflow system at any level, then whatever bile was draining through this to the GIT, their drainage will be impaired, and this bile will be regurgitated into circulation. And when this bile will be regurgitated into circulation, what really happens? We say not only bilirubin will go to circulation, but along with bilirubin, bile acids will go to circulation, even cholesterol will also go to circulation, right? And we call this condition cholestasis. Is that right? But sometimes what happens, problem is, let's suppose at this level that bilirubin cannot be conjugated, and unconjugated bilirubin go high in the blood. Under these circumstances, bile acids are drained well, right? And cholesterol is drained well. So only unconjugated bilirubin goes high in the blood. This kind of hyperbilirubinemia should not be called cholestasis, right? Now, if you really want to have a good concept about the jaundice, first you should understand the normal physiology of bilirubin. That how bilirubin is produced in the bodies, why bilirubin should be thrown out of the body, how bilirubin is carried in circulation, how it is dealt with by the liver, and in which form it appears into fecal matter, and in which form it appears in urinary system. Right? So right now we shall talk about normal physiology of bilirubin. After that we'll talk about the causes of hyperbilirubinemia or causes of jaundice. Right? Let's suppose here is your spleen. You know, the major source of bilirubin is from where? Breakdown of hemoglobin. Is that right? Hemoglobin and other heme protein like cytochrome and other enzymes, when they break down, right, they may release bilirubin. Now, let's suppose we talk about one RBC. You know, when RBCs, normally they are constantly being produced by the bone marrow. They are going to circulation. Then when they become, you can say, around 120 days old, right, they lose their plasticity and they get stuck into some narrow spaces in circulation like cords of Billroth in spleen. In the spleen there are some very narrow and tortuous points in which RBCs which are old, right, and which are not pliable RBCs, because fresh RBC is smart and pliable like fresh people, you know, like adolescents. But as you become old, you develop osteoarthritis and you also develop some degree of stiffness in your body and your mind even sometimes, unfortunately. Same is true about RBC. When RBCs, you know, RBC doesn't have a nucleus. Because RBC doesn't have a nucleus, so what really happens with RBC, when time passes by, RBC's proteins undergo denaturation. But because it doesn't have a nucleus, can it resynthesize new proteins? It cannot. It has kicked out its genetic machinery. So when its proteins become, you can say, denatured with the time and less functional with the time, then capability of RBCs to be pliable and twist and turn through the narrow capillaries is lost. That is the time for RBCs to get lost. That RBCs will get stuck into some narrow points. Most commonly in the spleen there are some very narrow circulatory points which are really test point for RBCs. We call them cords of Billroth. When a fresh RBC passes through that will twist and turn and move out, right? But if an old RBC comes, it will get stuck over there. And when RBC will get stuck into those narrow points in spleen or in some other points in bone marrow or in liver, then what really happens, that neighboring macrophages come into action and they eat up the RBCs. Because if RBCs go and stuck into spleen, do you think they should remain stuck there forever? Answer is no. So when RBCs get stuck over there, it activates the neighboring macrophages, and these macrophages basically phagocytose those RBCs. It means that RBCs break down within the circulation or within the macrophages. Yeah, that is the point to understand, that normally RBCs break down within the macrophages. That is why we say normally old RBCs don't undergo intravascular hemolysis, they go into extravascular hemolysis, actually intra-macrophage, monocyte macrophage system hemolysis. Is that right? Now we'll talk about, let's suppose there is one, let's suppose here is your spleen. Okay. In the spleen we make here we just make one macrophage. This is a large macrophage. And in this macrophage, this is RBC which this macrophage has recently captured. Right? Now we are going to see how macrophage deals with the RBC and how bilirubin is produced. Right? What really happens, that talking about that when a macrophage captures an RBC, what really happens with the RBC and its components, right? Now RBC basically consists of cytoplasm and its cell membrane. That's the major thing. And of course within the cytoplasm of RBC there is a lot of hemoglobin. Is that right? Let's see by the breakdown of the important component of RBC what we really get. Right? RBCs are broken down, number one, into membranes and their breakdown products. Number two, different types of cytosolic proteins and enzymes. Right? And then, of course, you should not forget there is hemoglobin. Is that right? Membranes, break down into, yes, lipids and proteins. Lipids will go eventually into free fatty acids, and proteins will break down into amino acids, and these substances can be utilized by macrophage for its own purposes. Right? So membranes are gone with the wind. They're finished. We are left with the proteins. What will happen with the proteins? Proteins will be also broken down into, yes, amino acids. And that story is also over. Now you are left with what? Hemoglobin. First of all, we should see what is the normal structure of hemoglobin, and then we'll see once it breaks down what really comes out. Let me tell you here what is the normal structure of hemoglobin. Is that right? Normal structure of hemoglobin, when we are talking about, basically this is a pyrrole ring. The single ring is called pyrrole ring. And if 4 pyrrole rings are put together, right? When 4 pyrrole rings are put together, this structure is called protoporphyrin. What is it? Protoporphyrin. This is pyrrole ring. So when hemoglobin synthesis starts, first we have to synthesize heme. And then we have to fuse the heme with the globin chain, and we end up with the hemoglobin. So what really happens in a hemoglobin synthesis, first of all we should synthesize pyrrole ring. Erythroblast synthesizes pyrrole ring, then pyrrole rings are put together to synthesize protoporphyrin. Then what really happens, that within the protoporphyrin, let's suppose I show protoporphyrin like this flower. Now of course these petals are pyrrole rings. In the protoporphyrin, if you put the iron, what you put? Iron. Now the structure is called, yes, heme. What is the structure? heme. And then what really happens that, let's suppose this is heme and here is iron. With that, if you bind a globin chain which should be made of what? Amino acids. Then this structure is called hemoglobin. What is this called? Hemoglobin. One heme with one globin is hemoglobin monomer. What is the structure? Hemoglobin monomer. Let's recap. Attention please. You start from the top. Pyrrole ring fuse with each other make protoporphyrin. Protoporphyrin incorporated with iron becomes heme. Heme fused with globin chain is called hemoglobin. Is that clear to everyone? Right now. This is hemoglobin monomer. Normally a full molecule of hemoglobin is a tetramer. How it is tetramer? Let me tell you. What really happens that, let's suppose these are 4 what is this? Protoporphyrins, and all of them are having iron, so they are 4 heme. And let's suppose here is alpha globin chain, here is also alpha globin chain, and here is, let's suppose, beta globin chain, and there is also beta globin chain. Now this whole structure is one hemoglobin tetramer. One hemoglobin tetramer. You must be knowing such kind of hemoglobin is called hemoglobin A, which is having 2 alpha chains plus 2 beta chains. In the same way, in place of beta chain, if you bring the gamma chains, it becomes hemoglobin F. And if there is delta chain, it becomes hemoglobin A2. Right? So anyway, now you know what is the basic structure of hemoglobin. Let's suppose we make a hemoglobin here. Right? Now, of course, this hemoglobin should be what? It should be having iron, and it should be having, what is this structure? Protoporphyrin. And with the protoporphyrin, normally it should have, what is this? Iron. So what is it? Heme. With the heme, if this is a globin chain, then what is this? Hemoglobin. Now what really happens? First of all, enzymes break down, what is this? Globin chain. When a globin chain will break down, it will also become the part of amino acid pool. It will also become the part of amino acid pool. After that, what is we are left with? Globin has gone. We are left with the heme, isn't it? With iron and other structure, remaining structure, we are left with the heme. Now what really happens? The next step is that enzymes will break down and bring the iron out. Now this iron which has been brought out, let's suppose this is iron. This iron is highly toxic molecule, and it will react with the different substances in the cell. It may damage the cell. So this iron should be put into a proper container. The container is that there is a special type of protein which is synthesized by the most of the cells which handle the iron. That protein is called, yes, what is the protein which handles the iron? Apoferritin. This is apoferritin. Now what really happens? Apoferritin and iron fuses together, and when both of them fuse together, they convert into a structure, and this structure is called ferritin. So what is the structure? Ferritin. Now, when many ferritins are put together, let's suppose we put many ferritin put together and make a polymer of ferritin. There is a polymer of ferritin, and this polymer of ferritin, right, this is called, yes please, very good, excellent, this is called hemosiderin. Okay, by the way, before we really go into detail of jaundice, what is the difference in hemosiderosis and hemochromatosis? Who will explain? Have you heard of these terms? Hemochromatosis and hemosiderosis, or never heard? You heard of it. So, Dr. Rafiq, would you like to tell? What is the difference between the hemosiderosis and hemochromatosis? Okay, write it down. Everyone has some normal amount of hemosiderin in the body. Iron is basically kept into storage form, and the storage form of iron in our body is mainly hemosiderin. When storage form of the iron become more than normal, but yet it is not damaging the tissue, it is called hemosiderosis. When hemosiderin become more than normal, but it has yet not started damaging the tissue significantly. This is called hemosiderosis. But if hemosiderin level further become high and start damaging the tissue, then we call the condition hemochromatosis. So what is hemochromatosis? Hemochromatosis is a condition in which hemosiderin level is so high in the body that tissues are being damaged. For example, liver will be damaged in hemosiderosis, pancreas will be damaged in hemosiderosis, your spleen will be enlarged, or maybe your heart, that may be damaged by hemosiderosis, that may produce some, right? Then the hemosiderosis may damage interior pituitary, this may damage many tissues in the body. So what I'm talking about, that hemosiderosis means simply high level of iron storage form, but yet not has started damaging the tissues. But if it has started damaging the tissues, then it should be called hemochromatosis. Now let's come back. We have solved the problem of the membranes, we have solved the problem of cytosolic proteins, now we are dealing with the problems of hemoglobin. That hemoglobin was divided into globin and heme, and globin was further divided into amino acids. Then we were left with the heme. This heme was divided into, iron and the leftover material. The leftover material is, what is this material? Yes, please. Yeah? This is not protoporphyrin, that is a ring structure, my brother. So what should it be? This is bilirubin. So this is how you produce the bilirubin in your body. From where the bilirubin comes, right? That is breakdown product of hemoglobin and other hemoproteins in the body. Is that right? So it is not protoporphyrin. If it was protoporphyrin, it could be recycled. Right? It is not protoporphyrin, it's a broken protoporphyrin, modified protoporphyrin, it is a wasted protoporphyrin, it's a toxic protoporphyrin, it is actually not protoporphyrin, it is bilirubin. Is that right? And this bilirubin, right, what were the enzymes on the way which handled with it? First of all, actually, it was made biliverdin. The first compound which is made is biliverdin. Then it goes one step more, and then it converts into, bilirubin. Now, the enzymes which are involved in this game, number one, heme is, first of all, converted, heme, it was here, converted into this form, biliverdin. The enzyme which is involved here is, which enzyme is here? What is the name of this enzyme? This is called heme oxygenase. What is the name of this enzyme? Heme oxygenase. So what is heme oxygenase? This basically break down the heme into biliverdin and iron. Iron is later on incorporated with apoferritin, becomes ferritin, and ferritin converted into hemosiderin. Is that right? Then what is there? Biliverdin. Biliverdin is acted upon by one more enzyme. This is acted upon by one more enzyme. And what is the name of this enzyme? What is the name of this enzyme? Mr. Abid must tell. Right, but it's not that simple, my friend. This is called biliverdin reductase. What is the name of this enzyme? The name of this enzyme is biliverdin reductase. Biliverdin reductase. Right? And now, it is a reduced form. When biliverdin is reduced, it becomes bilirubin. Now, this bilirubin will come out of, from where it will come out? Macrophages. Wherever they are. Wherever macrophages, they may be in the spleen most abundantly, or they may be present in the liver, or they may be present in the, you can say, bone marrow. So what really happens, that macrophages take up the RBCs and they release the bilirubin. Now you are clear that if somewhere it is written that macrophages take up the RBCs and release the bilirubin, you know what are the steps and what is really happening within the macrophages. Now we have to deal, this bilirubin is a highly toxic molecule. It's a dangerous molecule. It is constantly being produced in our body, and our body must get rid of it. So we'll talk about how we really get rid of this molecule. I told you that daily we produce how much bilirubin? 0.2 to 0.3 grams per day. How much bilirubin is daily produced? 0.2 to 0.3 grams per day. So somehow body should get rid of it, and during the process of getting rid of this substance, body should have some special precautions not to injure itself. Let's see that matter. So how body deals with it. We're going to talk about physiology of bilirubin first, and then we'll talk about pathology, right, and related therapeutic aspects and investigations. So we were talking about that, let's suppose here is spleen and this is a macrophage, and this macrophage has taken up one RBC. It's going to degrade the components of RBCs into simpler compounds. As we know that membranes of the RBCs will degrade into protein and lipids, and proteins will eventually degrade into amino acids. Lipids will break down to free fatty acids and other simple lipids, and proteins which are from other enzymes. You know, RBCs are a lot of enzymes. Do you know any enzyme in RBC? Yeah, any other enzyme you know? Pyruvate kinase, glucose 6-phosphate dehydrogenase. There are anemias related with these two enzymes. When there is deficiency of pyruvate kinase or glucose 6-phosphate dehydrogenase deficiency, patient may become anemic. Is that right? These are the minimum two enzymes you are supposed to know about RBCs. And of course then there are other structural proteins like ankyrin and spectrin, which are specially stabilizing the membrane of the RBCs. Anyway, all these enzymic proteins and structural proteins, they will break down into simple amino acids, right? Then what really happens, we are left with the hemoglobin. Hemoglobin will be broken into heme and globin, and again you know that globin will degrade into amino acids. Now we are left with heme. Out of heme, iron is extracted out, right? And iron is fused with apoferritin, and iron with apoferritin makes a monomer of ferritin, and multiple ferritin molecules fuse together to make a polymer which is called hemosiderin. Now we are left with the remaining component of heme, which has actually this structure, and this structure is called, yes please, this is called, initially it is converted into biliverdin, and eventually it is converted into, yes, bilirubin. And this bilirubin is pushed out into, yes, circulation. So this is a bilirubin which we have to deal with. Now this is very important bilirubin. What is the important point about it? This bilirubin, number one. First point which we have to talk about this bilirubin, that it's highly toxic molecule. And because this bilirubin is a highly toxic molecule, we have to get it out of the body, but in a safe manner. And once bilirubin is released from the mononuclear cell into circulation, we should trap it into circulation so that it does not leak back into other tissues. The first principle is that if mononuclear cells are releasing this bilirubin into circulation, we should trap this molecule into circulation so that it does not diffuse into many other tissues back to the body, because if this is held and trapped into circulation, then sooner or later it will pass by the liver, where liver will handle it. But what is the way to keep and trapped into circulation? Answer is, it's a small molecule. It has a tendency to leak out. So there are special bilirubin trapping proteins which are again synthesized by liver. Let's come, this is the liver. Here's the hepatocytes. I've drawn just two hepatocytes. This is biliary drainage system. You know, hepatocytes have one face. It's a very simple functional diagram. If we talk about this hepatocyte, this face of the hepatocyte is towards the blood side, and this face of the hepatocyte is towards, yeah, biliary system, right? It means the hepatocytes have basically two important faces. Number one, some part of the membrane of the hepatocyte face to each other, and one part of the hepatocyte membrane should be facing towards the space of disc and sinusoidal face, and this side of the face of the hepatocyte should be towards the, yes, biliary canalicular face. So it is just like that. There's a front road and there's a back road, right? So front road, what is moving here? Blood. In the back road, there's a drainage system, right? What is this drainage system? Yes, biliary system. Every hepatocyte has a front face, right, and it has a back face. In the front face, it is facing with the circulation. In the back face, it is facing with the biliary canalicular system. And remember one very important thing, that functional characteristics of this part of the membrane is very different than functional characteristics of this part of the membrane. As we'll go into detail, we'll talk in reference to bilirubin. Right now what I wanted to tell you, that one of the function of hepatocyte is that it will secrete special type of, you can say, proteins, and these proteins will go into circulation. And once these proteins go into circulation, one of the major functions of these protein is that they will immediate, as soon as bilirubin comes out, these protein will bind with bilirubin. That is why these proteins are called bilirubin binding proteins. They are part of the protein which are released by the hepatocytes daily into circulation. So we can say that this is the duty of a hepatocyte to provide the circulatory system with such proteins which are bilirubin trappers. Right? Once this bilirubin binds with this plasma protein, what really happens? That now the whole complex becomes very large. When this complex becomes very large, do you think this bilirubin can go back to the tissues? No. Okay. Can now this bilirubin, which is bound with the plasma proteins, right? Can this bilirubin filter out here and appear into urine? Answer is no, because normally proteins don't filter out. If proteins are not going into filtrate, how protein bound substances will go into filtrate? So it means this newly released bilirubin immediately bind with the bilirubin binding proteins, and after that rest of the body will become safe from it. Now this bilirubin, after binding with the protein, has developed two properties. Property number one is it cannot diffuse through microcirculation back to your many tissues. Property number two is it is unable to filter into urine. So it means this form of bilirubin will not produce bilirubinuria. If you find bilirubin in anyone's urine, be sure that bilirubin will not be this form, because this form is fused with proteins, and normally proteins don't filtrate in heavy amount. So protein bound bilirubin also does not. This type of bilirubin is called, first listen question. I know you are in hurry in answer, but still I will put a question in a decent way. You are a respectable lady. So this bilirubin molecule, once it is bound with the plasma protein, what type of bilirubin is this? Yes, please. Conjugated or unconjugated? It is conjugated bilirubin according to Dr. Tanzila. What about Dr. Amtal? It is unconjugated. Okay, then these ladies have to fight with each other, it means. One lady is saying this is conjugated bilirubin. Other lady says it is unconjugated bilirubin. How would you prove your point? How you will prove she is wrong?
It's yet to pass through the liver to become conjugated.
Yes, she is right. Because bilirubin gets conjugated within the liver, within the hepatocyte, and it has not yet gone to hepatocytes. Listen. Conjugated bilirubin does not mean that bilirubin fused with anything is conjugated. The term of conjugated bilirubin is used when bilirubin binds with glucuronic acid. When bilirubin is fused with glucuronic acid, then we say bilirubin is conjugated. And plasma proteins are not glucuronic acids, right? So when plasma protein bind with this bilirubin, newly released bilirubin, it is yet not fused with glucuronic acid. So it must be considered unconjugated plasma protein bound bilirubin. Is that right? Here there is one very important technical point. So I think just to remind you for next, we will correct this. We should write it unconjugated, yes, bilirubin. Unconjugated bilirubin, right? So when bilirubin released, it is unconjugated bilirubin. Initially it is free unconjugated bilirubin, then it is plasma protein bound unconjugated bilirubin. Here is a very important point. Especially in the gynae ward, doctors are very concerned that if newborn produces excessive amount of unconjugated bilirubin, they say there is increased risk of leakage of unconjugated bilirubin to the central nervous system and may produce a problem called kernicterus. That is called kernicterus. What is kernicterus? If bilirubin goes into heavy amount in central nervous system, of course not only it will morphologically impart a yellow color to the cerebral cortex and the basal ganglia, but actually it will damage them as well. It's a toxic to the central nervous system neurons, and that may lead to mental, if baby really survives, right? Then baby may develop clinical features related with mental retardation. Along with that, when damages to the basal ganglia, there may be motor dysfunctions as well. My question is this, that if unconjugated bilirubin is bound with the plasma protein, can plasma protein bound unconjugated bilirubin leak into central nervous system? What about blood-brain barrier?
It would not leak.
It should not,
Yeah.
but it will. I will talk about how. First of all, look, plasma brain, in the brain, the circulatory system, right, it is very tight in a way that in central nervous system, the capillaries which are passing through the central nervous system, their endothelial cells are stitched to each other very tightly, plus the astrocytes on the outside, and there is something called blood-brain barrier. Well, it is not really a truly physical barrier. Blood-brain barrier means everything which is present in the blood is not going to spill into interstitial microenvironment of central nervous system, in which neurons work up, right? Only smaller molecular things or highly lipid soluble things can move from the blood to the microenvironment of central nervous system. Is that clear? Now, our question goes back that why in newborn, if unconjugated bilirubin level is pathologically high, then there is a great risk that unconjugated bilirubin will go to the central nervous system. How would you answer to this question?
The blood-brain barrier is not that developed.
Okay, number one reason is that in the newborn, blood-brain barrier is not so well developed. And number two reason is more important. What is that? That as unconjugated bilirubin level goes high in the blood, there is a shortage of these proteins. And as unconjugated bilirubin level goes high and high, all the trappers of unconjugated bilirubin will become saturated, especially in the newborn, which has a limited supply of bilirubin binding proteins. So what really happens? That the fraction of unconjugated bilirubin, which is not bound to plasma protein, progressively increases, and that is which can flood into circulation, central nervous system microenvironment, and produce toxicity to the central nervous system. Okay, then what you will do for these kids? If there is a kid which is having very high, you can say, unconjugated bilirubin, and you are very much worried about that baby may not go into problems of canalicular, what will you do about this baby?
We could do an exchange blood transfusion.
Okay, one way is exchange blood transfusion in a very advanced stage. Excellent. What else you can do?
Phototherapy.
Phototherapy. You will show the photo of mother or father to the baby. Yeah. What is phototherapy? What is phototherapy? You know phototherapy?
Yeah, the light, there is special kind of light, blue ultraviolet light.
Okay, there's special type of light. We expose the baby to that for a long time, and then what will happen? The baby's color look less yellow in that light, or there's some other reason?
Some other reason.
What is that?
Bilirubin started passing out.
Rapidly out of the body. Why? Because that particular light makes the unconjugated bilirubin into special photoisomers. Special photoisomer which do not need to be conjugated by liver and can pass out. Because newborn's liver is also, you can say, relatively immature and not well equipped with all the enzymes and the concentration to handle with the flood of the unconjugated bilirubin. Is that right? Am I clear? Okay, another thing they have recently started, there's another thing what they have started giving to the babies is 10-protoporphyrin. What is this 10-protoporphyrin? There's something coming in the 10. This 10-protoporphyrin. What is 10-protoporphyrin? They started as a therapy of the babies who have the risk of canalicular. Yes, it is write it down please. It is synthetic metalloprotoporphyrin. It is synthetic metalloprotoporphyrin. It is 10-protoporphyrin. It is a synthetic metalloprotoporphyrin. It is a potent competitive inhibitor of hemoxygenase. It is a powerful inhibitor of hemoxygenase. And now look here, if there is a newborn baby and you have given him 10-protoporphyrin, and 10-protoporphyrin goes into macrophages and inhibits the hemoxygenases, then power of the hemoxygenases to produce biliverdin and eventually bilirubin has been reduced. So in this way, when we give 10-protoporphyrin to the newborn baby, we reduce the rate of production of unconjugated bilirubin. At the same time, we expose them to the special wavelength of the light, so that whatever unconjugated bilirubin is already produced, this should rapidly convert into such photoisomers which can be expelled out of the body very rapidly without depending on the conjugative process of the liver. Okay, let's go ahead. So we were talking about this is unconjugated bilirubin, which is bound with the plasma protein. Normally it cannot enter into central nervous system, even it cannot go to many other tissues. It cannot filter into urine, so and it is highly toxic but trapped. Highly toxic but trapped. Now what really happens? That I told you, these substances were produced by liver, and then they are going and binding this. Once this becomes fully loaded, once plasma protein, bilirubin binding pre-albumin and bilirubin binding albumin, they're fully loaded, they will take this bilirubin through the circulation. Of course, his hepatic artery and portal vein are still going to the liver, right? And from general circulation, these unconjugated bilirubin along with the plasma proteins through the hepatic artery or through the portal circulation, they will go to the liver. You know, hepatic artery blood and portal circulation, vein blood mix with each other in the hepatic sinusoids. So eventually this will be taken to the hepatic sinusoids. When these are passing by the hepatic sinusoid, this was what? Yes, unconjugated bilirubin. As along with the plasma protein, as they are passing by this, there is a very special type of molecule which is present over here, and it will love to bind. Yes, it will love to bind what?
Conjugated
There is a special receptor and uptake mechanism which is present on the sinusoidal face of the hepatocyte, right? As soon as unconjugated bilirubin along with the plasma protein come near to it, it will transfer this bilirubin into, yes, hepatocytes. So hepatic uptake has been done. And here you must know there are few things which interfere with the hepatic uptake. Can you tell me some substance which can interfere with the hepatic uptake? Any substance you have ever heard of it? There are many drugs which bind here and reduce the hepatic uptake. Okay, from the drugs I remember, some drugs can displace the bilirubin from this point. Some drugs can interfere with the bilirubin handling here, uptake. Some drugs may impair the conjugation of the bilirubin. Some drugs may impair the secretion of bilirubin. Now, you have to tell me few drugs which can displace the, what is this? You have to tell me few drugs which can displace the unconjugated bilirubin from plasma protein, and at least one drug which does not allow the uptake of it or interferes with the uptake. Yeah. Do you know any drug which will displace it because clinically important? Because if you are giving those drugs to a person who is jaundice, for one or the other reason you are giving those drugs, bilirubin level will go up, free bilirubin. Especially if you give those drugs to babies, right, newborn babies, you give those drugs, unconjugated bilirubin will be displaced, and now you know where it is headed for, to the central nervous system. Is that right? Do you know any drug like that? At least one drug which may be used for one or the other reason in the newborn even? Yeah. Why don't you tell me sulfonamides? Write it down, please. These are the displacers of unconjugated bilirubin from plasma proteins. Displacers of unconjugated bilirubin from the plasma proteins. The drug which displace bilirubin from this side, especially in the newborn, they increase the risk of icterus. Good doctors should know the name of those drugs. Sulfonamides, you know, in newborns sometimes there are infections and we have a tendency to use sulfonamides. Be careful. Sulfonamides in the newborn, especially we use for which purpose? For which purpose we use sulfonamides? Please tell me. Meningitis. Have you heard of it? Neonatal meningitis. Then penicillin derivatives. Sometimes if you are giving some babies heavy amount of penicillins for some other reason, but derivatives of penicillin may displace the unconjugated bilirubin from the plasma protein and produce trouble to the person. Then of course, not in babies but in adult people, even furosemide and radiographic contrast material can also displace the bilirubin from the bilirubin binding proteins. Anyway, once bilirubin has been in the bound form, has been taken to the liver circulation, and from the sinusoidal side, it will go to space of disc, and from there it should be taken up into hepatocyte. There's some drugs which interfere at this point. At least one drug you must tell me, because these drugs will produce unconjugated hyperbilirubinemia. The classical drug here is, I will give you an idea. That drug is usually used in anti-tuberculosis therapy. Then another thing I will tell you about that drug. Yes, that produces your all secretions orange color. Even ladies' lens will become orange color. Rifampicin. You remember it from ladies' lens, isn't it? Yeah, all the secretions will become pink, not truly red. Right? Patient will sweat pink. He will have the truly pinkish, bloody type of what these tears. Even saliva will become pink, and even after taking rifampicin, your lens, which lens? Artificial lens, right? They may become permanently stained pink color, right? So that also rifampicin loves to bind here, and it reduces the uptake of bilirubin sometimes in some patients. Clear? Anyway, let's go ahead. Once bilirubin has gone in, this is conjugated or unconjugated bilirubin? Unconjugated. It is unconjugated bilirubin. It has come in. It will enter into endoplasmic reticulum. It will enter into a endoplasmic reticulum. It will enter into endoplasmic reticulum, and within the endoplasmic reticulum there is a very important enzyme, and name of this enzyme is, yes, what is the name of this enzyme? Glucuronyl transferase. Now I want to highlight one thing. Look, to get this bilirubin out of the body, we have to make it more polar. We have to make it more polar. We have to make it more charged, so that it becomes water soluble and it is no more lipid soluble. Now, when you want to make a substance more polar or less lipid soluble or more water soluble, one way to do so is that make the substance more charged, right? And one way to make a substance more charged is that you take the substance to the liver, hepatocytes, and hepatocytes produce highly charged molecule. For example, hepatocyte convert glucose into gluconic acid, into glucaric acid, and that into glucuronic acid. What hepatocytes are doing? Hepatocytes are able to convert glucose into glucuronic acid. Glucuronic acid is a highly polar compound, right? Then hepatocytes, once they synthesize the glucuronic acid, they are having a special enzyme which is called UDP, glucuronyl transferase, right? You just call it GT. GT is glucuronyl transferase. So this is our enzyme which should be called glucuronyl transferase. Is that right? Now this glucuronyl transferase, this enzyme is normally abundantly present in the liver, especially in the endoplasmic reticulum, and its duty is that it will fuse the glucuronic acid with unconjugated bilirubin, and now bilirubin become conjugated with glucuronic acid. Now bilirubin should be called conjugated bilirubin. So this unconjugated bilirubin is now, what is happening to this? It is fused with, yeah, glucuronic acid, and after it is bound with the glucuronic acid, we call it, yes, conjugated bilirubin. This is now conjugated bilirubin. Now it is called conjugated bilirubin. Now this conjugated bilirubin, okay, I'll make it black. Some people like the black things too much. This is now conjugated bilirubin, right? This conjugated bilirubin is highly, it is conjugated with glucuronic acid, so this is highly what? Polar. Once it is polar, can it dissolve into lipid membrane of hepatocyte? No. So it means now conjugated bilirubin is trapped within the hepatocytes. Now it is trapped within the hepatocyte. If it is trapped within the hepatocyte, now it is up to the hepatocyte, attention please, that hepatocyte will throw it to the blood or to the biliary canalicular system. Now it is up to hepatocyte. Actually hepatocytes have already planted, in the honor of this molecule, special type of transporters, yeah, on which side? These are active transporters, and these special transporting molecules which are present on the canalicular canalicular face of hepatocyte, they are expressed over there. They are capable of catching the conjugated bilirubin from the hepatocytes and expel into where? Biliary canaliculus. So they are responsible, these pumps, they will throw it into biliary canalicular system, and this conjugated bilirubin has now gone into the system, as I showed you that this was the pump system, and this pump system is actively transporting the conjugated bilirubin from intrahepatic site to the biliary canalicular system. Now, this bilirubin, which is now conjugated bilirubin, it will pass through the biliary drainage system. There is no fun in telling that there is biliary canalicular system which go into biliary ductules. Then there is right hepatic duct, there is left hepatic duct, they fuse together, make a common hepatic duct. And of course bile also comes to gallbladder, where what major thing happens to bile in the gallbladder? Yes, what gallbladder is doing with the bile? Number one, concentrating, right, and many other things as well. But anyway, it will come here for the storage and concentrating. Eventually bile along with conjugated bilirubin, of course with the conjugated bilirubin, bile will have bile salts and acids. What are bile acids? Can you name bile salts or bile acids? Cholic acid and chenodeoxycholic acid. Deoxycholic acid and chenodeoxycholic acid. They are fused with taurine and other amino acids to convert into salt. Anyway, bile salt and bile acids along with the conjugated bilirubin, along with cholesterol and lecithins, they, of course many other inorganic material as well, especially bicarb, they are taken down through biliary system. In this way, conjugated bilirubin is now headed towards your, yes, to your GIT. Eventually, the final destination is your GIT. From here, conjugated bilirubin will come over, yeah, this is conjugated bilirubin. It has been released to GIT. Of course, this point is called ampulla of Werther, and it is having a sphincter which is called sphincter of OD. Once the conjugated bilirubin comes here, once the conjugated bilirubin comes to the GIT, now eventually what will happen to this conjugated bilirubin? It will undergo further modifications. There are a lot of enzymes which are present in GIT, plus a lot of microbes which are present in your GIT, right? And this conjugated bilirubin as it is passing through GIT, it is acted upon by, yeah, bacteria and enzymes, different bacteria and different enzymes, and they may convert this conjugated bilirubin into another compound which is called urobilinogen. What is it called? Urobilinogen. Now listen, you know from GIT the portal blood is taking some absorbed material to the liver, right? Now what really happens, you know, portal blood take a lot of blood, you know, from the GIT, and this blood is going to the liver, and of course portal blood also passes, from where it passes? Portal blood is going to the liver and eventually drain into sinusoidal system and sinus, right? Now what really happens there? Actually this urobilinogen, right? This is a small part of that is taken up by, yes, taken up by GIT. It is reabsorbed, small part. But major part is more destined to the last part of the gut, where it will convert into, yes, stercobilinogen, and eventually it will pass into fecal matter, and this stercobilinogen is responsible to giving a characteristic yellowish brown color to the fecal matter normally. Is that right? Stercobilinogen. But the urobilinogen, which has been absorbed from here, right, it will pass through the portal circulation, and as portal circulation will be passing through the hepatocyte, part of urobilinogen may be taken up by again sinusoidal side of the hepatocytes and recycled from here. Right? But real problem is that a very small percentage of it may escape into urobilinogen into circulation. This urobilinogen, it is a polar compound and it does not bind with the plasma protein. This is a charged compound. So this urobilinogen, urobilinogen, it's a polar compound but not bound with the plasma protein. Because it is not bound with the plasma protein, it will easily filter into urine. And because it is, what is it? It is polar, it cannot dissolve into nephrons epithelial cells, so it cannot come back. So this urobilinogen is headed to be part of your urinary output. So in this way, every normal person should pass at least small amount of urobilinogen in urine. Is that clear? Any question here? Now, this finding should tell you one thing. If a patient comes to you and patient is having jaundice, if you take the urine of the patient and with dipstick you check, is urobilinogen there or not? If urobilinogen is not there, if urobilinogen is not into urine, it means it is not present in the blood. If it is not present in the blood, it means it was not present in GIT. If urobilinogen was not present in GIT, it means conjugated bilirubin never came here. It means, where is the problem? Outflow. If your blood has lot of conjugated bilirubin, listen now carefully. If someone has hyperbilirubinemia, a lot of conjugated bilirubin is spilling into blood, but there is no urobilinogen into urine, it means problem is somewhere between this point to this point. So it's very simple, that whenever a patient comes with conjugated hyperbilirubinemia and you just check with dipstick and there is no urobilinogen, you must think there is some cholestatic problem, there is some bile outflow problem, right? Now, what I was talking about, that this urobilinogen which was retained within here, it may convert into stercobilinogen, which will be passed into fecal matter, and if fecal matter is left into open air, oxygen will react with that and convert stercobilinogen into stercobilin, which is more darker color, right? Right, now we will be talking about, once we have done with the physiology of bilirubin handling, now we will talk about that under what circumstances hyperbilirubinemia develops, which may eventually become a cause of jaundice. As you know, that normal bilirubin levels are, considered 0.2 to 1.2 milligrams per dl. This is total plasma bilirubin. Total plasma bilirubin. Of course, this total plasma bilirubin should be divided into two parts, that is unconjugated bilirubin and conjugated bilirubin, right? So normally bilirubin level is this much. Due to any reason, if bilirubin level in the blood start going up, right, we say patient is developing hyperbilirubinemia. But when hyperbilirubinemia is sufficient enough to impart the yellowish coloration to your skin and mucous membrane and sclera and interstitial fluids or tissues, we say patient is jaundiced. Is that right? Now, whenever a patient comes with jaundice, of course, the patient will have total bilirubin very high. But as a good doctor, you must determine that the major component of high total bilirubin is unconjugated bilirubin or conjugated bilirubin. In some patients with jaundice, the dominant component of excessive bilirubin is unconjugated. In other patients, the dominant component of excessive bilirubin is conjugated bilirubin. So it means that whenever you have a patient with jaundice, you have to think in the term of that patient is having unconjugated hyperbilirubinemia or patient is having conjugated hyperbilirubinemia dominantly. Now, let's talk about why hyperbilirubinemia develops and what are the causes which lead to unconjugated hyperbilirubinemia and what are the causes which lead to conjugated hyperbilirubinemia. We'll start from this side. One mechanism may be that there is excessive release of unconjugated bilirubin to circulation. due to any reason, if your body starts producing excessive amount of unconjugated bilirubin to circulation, is that right? It's quite possible that the total bilirubin is released in such a rapid rate that liver cannot handle that well. And then unconjugated bilirubin start damming up into blood. This is one mechanism. Second mechanism is that bilirubin production is normal, but there is interference or problem in the bilirubin uptake. Mechanism number 2. Mechanism number 3 may be the bilirubin production is normal, bilirubin uptake by the hepatocyte is normal. Problem is with, yes, conjugation. That bilirubin, once it is taken up, it is not conjugated properly. Now, the group of patients with a problem either at level number 1, that is excessive bilirubin production, or problem number 2, poor hepatic uptake of the bilirubin, or problem at level number 3, that poor conjugation. These 3 groups of patients tend to develop unconjugated hyperbilirubinemia, right? Then after that, if someone has a problem beyond or distal to this point, for example, a person who is developing normal levels of bilirubin daily, producing normal level of bilirubin, hepatic uptake of the bilirubin is almost normal, conjugation is also normal. So it means whatever bilirubin is entering into hepatocyte, it is in a normal fashion, it is conjugated with glucuronic acid. Sometimes with bilirubin molecule we bind with one glucuronic acid, sometimes we bind with one bilirubin molecule to glucuronic acid. So it means liver is responsible to produce monoglucuronides and diglucuronides of bilirubin normally, right? After that, if person has problem at level number 4, what is the level number 4? Problem is with the active transport of bilirubin and other substances from the hepatocyte to the biliary canalicular system. It means dysfunction is on which side of the hepatic membrane? Hepatocyte membrane? Canalicular face of the hepatocyte membrane, right? Now in mechanism number 4, bilirubin is getting conjugated but not getting to the biliary system, so it will spill back to circulation. So it will become what kind of hyperbilirubinemia? Conjugated hyperbilirubinemia. Then another cause of conjugated hyperbilirubinemia may be, intrahepatic obstruction to the outflow, and then there may be, yes, extrahepatic obstruction to the bile outflow. Now cause number 4, 5 and 6, they will produce what kind of hyperbilirubinemia? Conjugated hyperbilirubinemia. So first you should be able to determine your patient is really their jaundice is there or not. It means total bilirubin should be high, and right, once you know there is jaundice or you know there is hyperbilirubinemia, the next step is to determine is it unconjugated hyperbilirubinemia dominantly or is it conjugated hyperbilirubinemia dominantly. If it is unconjugated hyperbilirubinemia, then problem is at level number 1 or 2 or 3. It means either patient is producing excessive amount of bilirubin, or there is reduced hepatocyte uptake of the bilirubin, or there is reduced conjugation by the hepatocyte. And if patient has conjugated hyperbilirubinemia, then causes may be either problem is with the hepatocyte to transfer the bilirubin from interior of hepatocyte to the biliary canalicular system. A problem is there is biliary canalicular system within the liver is dysfunctional, intrahepatic, yes, obstruction or cholestasis, and there is some other outflow obstruction outside the liver, which may be in the right and left hepatic duct, or it may be in the common bile duct, or it may be at inflow of water, right? These are called extrahepatic bile outflow obstructions. Is that right? All of these mechanism 4, 5 and 6, they will lead to conjugated hyperbilirubinemia. Now, let's start working upon our patient. Let's suppose you are in charge of the jaundice clinic and patients are coming over there, right? So, diagnosis of jaundice is not enough. If you are making the diagnosis and the patient is having jaundice, it is no diagnosis in fact, because you have to look for the cause always. Different patients may have jaundice due to different reasons which need to be managed in a different way. So jaundice is no diagnosis, right? A good doctor will always look beyond that. Is there jaundice or not? If jaundice is there, what type of hyperbilirubinemia is there or not? What is the underlying mechanism and cause of that, and how to manage that? Now we'll talk one by one. Let's start with the mechanism number 1. The patients in which there is excessive production of bilirubin. So first of all, we'll talk about what could be the causes of excessive production of bilirubin. Yes, please. With patient who come into group number 1, and patient who are coming to the group number 1 are those patients who are having excessive production of bilirubin in their body. Now we have to think over why some people may have excessive production of bilirubin, right? Can you tell me any reason? Yes. Hemolysis. Do you think hemolysis will always produce excessive bilirubin? Answer is no. Because daily we have physiological hemolysis. Normally RBCs after about 120 days undergo physiological hemolysis. They are taken up by the macrophages, and these RBCs are rapidly destroyed within the macrophages. It means that hemolysis is within the circulation or within the cells? Within the cells. So that physiological hemolysis which occur within the cells, we call it extravascular hemolysis, because it is not within the vessels, it is outside the vessels into cells, macrophages, right? So number 1 thing is that hemolysis occurs physiologically, right? So, and we don't develop jaundice with that usually. So then my question is that what are the conditions in which there is excessive production of bilirubin? You will say excessive hemolysis. Answer is not hemolysis, answer is excessive hemolysis. All hemolytic conditions, right, which break down RBCs excessively and they produce so much bilirubin which liver cannot handle, then what will happen? What will happen? Unconjugated bilirubin level will go up into blood. Is that right? Now, remember here, if the cause of unconjugated hyperbilirubinemia is just excessive production, usually bilirubin level in the blood does not go more than 5 to 6 milligram per day. Again, let me tell you. If you have a problem due to which you are producing excessive bilirubin, whatever excessive bilirubin you produce, if your liver is functional, liver is capable of handling extra bilirubin, that it won't allow, yes, it won't allow unconjugated bilirubin to dam up into blood more than 5 to 6 milligram per dl. What does it really mean? It means if a patient comes who has unconjugated hyperbilirubinemia and his level is 10 milligram, it means problem is not with excessive production, probably problem is also with the uptake or conjugation. This is a mixed problem. Am I clear? Is it clear? Now, we were talking about what are the conditions in which there is excessive production of bilirubin. Of course, when there is excessive hemolysis. Now, excessive hemolysis may be sudden, severe excessive hemolysis. Number 1 in hemolytic anemias. Hemolytic anemias, where breakdown of RBCs will be very rapid and bone marrow is trying to compensate, but it cannot compensate, so hemoglobin levels start going down into blood. Number 2, absorption of large hematomas. Absorption of large hematomas. If you have a large bleeding within the body and RBC is ruptured within the body, for example, you may have intraperitoneal hemorrhage, or in the gynae there are some reason, gynae that there may be large hematoma formed, or then later on. Yeah, very good, very right. Ectopic pregnancy, or if person survives, right, then patient will develop jaundice, otherwise not, right? If there's ruptured ectopic pregnancy or there's ovarian cyst or intra-abdominal hemorrhage, right, what really happens that if patient survives the acute collapse, you have been there and managing it well, then what really happens? A lot of RBCs which are present in the body, they rupture rapidly. A lot of macrophages go over there and try to convert that hemoglobin into bilirubin. And so much unconjugated bilirubin may flood into your circulatory system that liver cannot deal with it that efficiently, and that may translate into unconjugated hyperbilirubinemia. Then of course we can talk about abruptio placenta, which has, which one? Revealed hemorrhage is responsible for jaundice later on, or concealed hemorrhage? Concealed, of course. In abruptio placenta, when placental attachment partially abrupts from the uterine attachment, and some hematoma may be having concealed blood collection between the placenta and the uterine wall, or even RBCs infiltrate into myometrium, which make it board-like rigidity and painful, right? So that RBCs will also absorb, and later on they may increase the load of bilirubin to the liver. And if a lady is unable to handle that excessive amount of, lady's liver is unable to handle the excessive amount of bilirubin, she may develop unconjugated hyperbilirubinemia. So I'm talking about that different type of hemolytic anemias or absorption of large amount of hemolysis, hematomas that may lead to transient unconjugated hyperbilirubinemia. Sometimes that may produce mild jaundice. Then any other condition? Yeah. Physiologically, hemolysis occur at two stages of erythropoiesis. Who will tell me what? Some hemolysis occur during the erythropoiesis. You know, when ladies are cooking things in the kitchen, there are some intra-kitchen losses which never reported on the dining table. Is that right? In the same way, when bone marrow is cooking the RBCs, intra-bone marrow losses of RBCs occur. That is called which hemolysis? Yes.
Physiological hemolysis during erythropoiesis.
Okay, she has given a big statement. Physiological hemolysis occurring during erythropoiesis. That is about 10 to 15% of normal erythropoietic process. Is that right? And in some diseases, this is one hemolysis, physiological. Secondly, when RBCs jump into circulation, they will complete their circulatory time and then they undergo terminal hemolysis. So there can be hemolysis during the erythropoiesis and hemolysis after the RBCs have completed their circulatory time. Both can be physiological. Now, in some conditions, intramedullary hemolysis, we call that intramedullary hemolysis. Physiologically, intramedullary hemolysis is 10 to 15 to 20%, 10 to 20%, right? It means for every 5 RBCs intact, 1 RBC is destroyed before it appears into circulation, right? Of course, those RBCs are also taken up by macrophages, and then what happens? They are also responsible to add to the unconjugated bilirubin pool of the body. Is that right? In some conditions, intramedullary hemolysis become very excessive. For example, in some conditions, 80% of the RBCs which are being produced during the erythropoietic process are destroyed within the bone marrow before they appear into circulation. This is excessive. Can you tell me some conditions like that? You understand my question? It's in English. I'm talking about that sometimes erythropoiesis is going on very rapidly in bone marrow. And due to some dysfunction, intra-bone marrow losses become percentage-wise very heavy. That for every RBC, 1 RBC spilled into circulation, 4 may be destroyed within the bone marrow during the erythropoietic process. We call it that there is pathologically excessive what? Intramedullary hemolysis. So what could be the reason for that? Please tell me any
Thing which is producing abnormal type of RBC.
any severe condition in which bone marrow is doing its best. It has accelerated erythropoiesis, especially in pernicious anemia, B12 deficiency, and then in every B12 deficiency is considered pernicious anemia or not? But how do you define pernicious anemia?
Pernicious anemia is the absence of the intrinsic factor.
Okay, you remove my stomach. For example, you become angry with me, you remove my stomach and throw it to some birds, and you connect my esophagus with the duodenum. Do you think I will develop pernicious anemia? Answer is no. But I won't have an intrinsic factor. So this is not enough to say that deficiency of intrinsic factor is just pernicious anemia. A very good doctor, you have given an answer from a good doctor, but a very good doctor will say pernicious anemia is megaloblastic macrocytic anemia produced due to deficiency of intrinsic factor, which must be due to autoimmune process directed against parietal cells and intrinsic factor itself. Look, whenever you have deficiency of intrinsic factor, if deficiency is due to autoimmune process, then it is pernicious anemia, otherwise it is not. Is it clear? So post gastrectomy, right, intrinsic factor deficiency should not be labeled as pernicious anemia. Anyway, if someone has pernicious anemia or folic acid deficiency anemia and bone marrow is really accelerating its erythropoiesis and a lot of abnormal RBCs are made, and they, before those RBCs spill into circulation, they are destroyed within the intramedullary cavities, where that may produce heavy load of unconjugated bilirubin to the circulation. Liver cannot handle that, and that may end up into unconjugated hyperbilirubinemia. So we can say that excessive, yes, what is this? Excessive intramedullary hemolysis. So all these conditions have a tendency to load the body with excessive amount of bilirubin, and if liver cannot handle all that bilirubin, unconjugated hyperbilirubinemia will be there. Now, with all these things, there's some other features as well. This is called prehepatic. You can say prehepatic jaundice, because the problem of the jaundice is not due to hepatobiliary dysfunction. Problem is that normal hepatobiliary system is overloaded with the unconjugated bilirubin. Now, how you really know that, let's suppose a patient comes with jaundice, how you really know that problem is prehepatic? Let's talk about the parameters related with that. Okay, this is the investigations or some important pointers, right? If a patient has, okay, I will make these scenarios later, right? We'll talk about the clinical scenarios later in the lecture. I will continue first with the basic concepts, causes and concepts. Then we'll go to the clinical scenarios and laboratory interpretations of abnormal results of liver function test and hematological and serological results. Now, we have talked about this. Here you have to remember excessive hemolysis. Then if there is excessive displacement from the bilirubin here, you have to remember at least one drug. What is that? Sulfonamides. Then I told you there are some mechanisms in which uptake of bilirubin by the liver is reduced. For example, I told you rifampicin, right? After that, we come to the conditions in which problem is with the conjugation. That conjugating power of liver is reduced. It means that there is poor conjugating power of the liver. Now, when we talk about that impaired bilirubin conjugation, at the top must be physiological jaundice of newborn. Right? In physiological jaundice of newborn, the one of the major reason is that hepatobiliary system is immature. Hepatocytes have not yet expressed the genes related with formation of glucuronyl transferase with full power. So baby's liver, newborn's liver has, you can say hepatocytes have an undersupply of glucuronyl transferase. Number one problem. Secondly, you know, when baby is born, fetal hemoglobin is breaking down. So slightly extra load of unconjugated bilirubin to the liver and significant impairment in the conjugating power of the newborn's liver. So both of these are combined together to produce slight elevation in unconjugated bilirubin in the blood. So newborns usually develop what kind of hyperbilirubinemia? Unconjugated hyperbilirubinemia. They produce unconjugated hyperbilirubinemia, right? Okay, so this is one cause, that there is problem with the conjugation. There is decreased enzyme activity in the. Secondly, not only their hepatocyte is hepatobiliary, both systems are disturbed. In newborn, not only they poorly conjugate the bilirubin, rather they have one more problem, that whatever they conjugate, they do not effectively throw here, right? But main problem is poor conjugation. Is that right? After that we come to another, there is another term used, breast milk jaundice. What is breast milk jaundice? What is breast milk jaundice? I think someone put music with this information. So, yes. What is breast milk jaundice? No one knows about it. You should know it, isn't it? Okay, let me tell you that actually in the breast milk there are some enzymes which break down the conjugation between the bilirubin and glucuronic acid. So we call them breast milk D-glucuronidases or simply glucuronidases. Now, normally Physiologically, in the breast milk, there is significant amount of glucuronidase enzyme. Now, if baby is heavily fed through breast and not on other sources, what will happen? That breast milk, when it will go to the GIT, in the baby's GIT, whatever conjugated bilirubin is coming, it will deconjugate that. Whatever conjugated bilirubin is coming, breast milk enzymes will break down that conjugation process. Is that right? And what will happen? Unconjugated bilirubin will be again take up into circulation, and that may become unconjugated hyperbilirubinemia. Is that right? So this is one problem more, right? We call it breast milk jaundice, right? Then we come to some more causes. There are some syndromes. Now we are entering into the valley of syndromes. Okay. This is which enzyme? Please name it. Glucuronyl transferase. Of course, this is a protein. So proteins are synthesized by the expression of genes. Now, if we do something wrong with the genes concerned with the synthesis of this enzyme, it is quite possible synthesis of this enzyme become impaired. Is that right? Now, let's talk about inherited disorder in which you inherit the defective genes, where you are inheriting defective genes which are supposed to synthesize glucuronyl transferase. Now, it's very easy to talk about this, that in these hereditary conditions, there may be mild deficiency of glucuronyl transferase, yeah, or there may be moderate deficiency of glucuronyl transferase, or there may be severe deficiency of glucuronyl transferase. Of course, there are how many genes which are making this enzyme? At least there should be how many genes to make this enzyme? You never counted it, too busy in your life. Yes, have you been counting it? It's too easy. One gene should come from mother and another should come from father. So minimum for everything you should have two genes. Except Y chromosome, which only come from the father. Right? Most of the genes are present as double copy, one maternal and another paternal. Is that right? So it means that problem may be with the genes, right? With one gene or both genes. And problem may be producing mild deficiency of this enzyme activity, or moderate deficiency of this enzyme activity, or severe deficiency of this enzyme activity. Is that right? Now, in about 2 to 7% of the population, 2 to 7% of the population, there is mild deficiency of this enzyme activity. In 2 to 7% of the population, there is mild deficiency of this enzyme. So in these people, there is a tendency to keep all the time slightly high level of what? Unconjugated bilirubin. But usually it is not enough to produce jaundice. But if these people undergo some sort of stress, they may undergo fasting, especially more than 24 hours, or they undergo dehydration, or they undergo excessive physical activity. Under all these circumstances, these people tend to develop mild jaundice due to unconjugated hyperbilirubinemia. And in these patients, all other things are normal in their body. Now here I want to highlight one thing. You know, before I really go to the function of this enzyme, I will go to discuss about the height of the human beings. You know, the people, for example, if we say that human female, what is the average height of human female? Yeah?
5'4".
I think you have been meeting with, including the Western and Eastern both world, it must be 5?
1.
Okay. I think it's around 5'4" or 5'3", depends on what kind of female you are coming across. Okay, we keep with this young man's idea that average height is, most of the females have height around 5'4". Is that right? Their number is very high, such females. Then females who have a height of 5'2", they are less. Females with the 5'1" are less. Having only 5 is less. And of course having 4 is extremely less. And of course there are females which are taller than the average female. So the females who are 5'6", they are also less in number. There is a percentage. And females which are 5'8" are less. And thank God females with 5'10" are very less. And females with 6 are, alhamdulillah, very rare. Now what we really find, that this is normal characteristics. Do you think, if we say that normally female has a height of 5, on average 5'4", suppose, If you come across a female which has a height of 5, do you think she's abnormal? Or if you come across a female which is 5'8", is it abnormal? No. We say this character of height is distributed in a Gaussian fashion, Gaussian curve, bell-shaped curve in human population. This concept is clear? And these females in the very beginning, too short and too, not long, actually tall, females just present what? Ends of the Gaussian curve. Is that right? Same is true about many other functions, including your efficiency of glucuronyl transferase. There are a lot of people who have average activity of glucuronyl transferase. Some have really very excessive activity of glucuronyl transferase. Some people have relatively less power of glucuronyl transferase. So people who come at the end of, if this curve is for the glucuronyl transferase activity, right, then the people who come to this end of the curve, they are 2 to 7%. These are not significantly diseased people, rather they are not diseased people. These people have some mutations in their gene, which are especially mutations in the promoter boxes. Their gene does not express fully. In 2 to 7% of the population, the gene does not express, glucuronyl transferase genes do not express fully, but whatever messenger RNA they make, they're normal, right? So they do make glucuronyl transferase enzyme, but in slightly less concentration in their hepatocytes. Due to that reason, whenever there is extra challenge to the liver with unconjugated bilirubin, they cannot handle and they develop unconjugated hyperbilirubinemia. Now, this population is extremely important to diagnose. You know why? Extremely important. Because number one, their number is very high, 2 to 7% or on average 5% of population. Number two, these people develop mild jaundice many times in their lifetime. They all the time, they are keeping unconjugated hyperbilirubinemia, and as I told you, when these people have stress, they may tend to develop mild jaundice. But the liver enzymes are normal. There are no features of excessive hemolysis. Liver enzymes are normal. There are no features of outflow obstruction, biliary obstruction, right? Why they are so important? Because you diagnose them and tell them that this hereditary problem is not dangerous, so that they don't undergo undue, excessive, repeated investigations for their jaundice. It is just the end of the normal Gaussian curve. Is that right? So whatever unconjugated bilirubin goes up in their blood, that usually does not produce any disease problem to them. That does not produce any dis-ease. The only dis-ease is created by the doctors. We do not diagnose this condition, and even they don't know this condition, so they keep on sending them, okay, this time I could not find anything, next time when you develop this thing, please come to me again. So I want to know, what is the name of this condition? Yes, Dr. Antal, Dr. Tanzila. At least we should know the name of this condition, isn't it? This is called Gilbert syndrome. Have you heard of Gilbert syndrome? That is that thing, Gilbert syndrome. So, what is this? Yes, please. This mild problem is? Yeah? Gilbert syndrome. So, today onward, what is Gilbert syndrome? Not a dangerous thing, very common thing to be diagnosed only to reassure the patient so that patient does not undergo repeated undue investigations. Is that right? These patients have, you can say, a lower end of normal range of enzymes. Enzyme is just too low, but not so low to produce dangerous pathologies. Is that right? Am I clear? Now we come to the problem who have moderate and severe deficiency. The people who have moderate or severe deficiency of these enzymes, they are labeled as Crigler-Najjar syndrome. Crigler-Najjar syndrome. Right? Now this Crigler-Najjar syndrome again is of two types. Crigler-Najjar syndrome is again of two types. In one type of Crigler-Najjar syndrome, what really happens, that there is severe deficiency of what? Glucuronyl transferase. And in other type, there is moderate deficiency of glucuronyl transferase. Right? So what really happens, that this is, which is having a severe problem, this is called Crigler-Najjar type 1. And this which has moderate problem is called Crigler-Najjar type 2. Is that right? Again, let me repeat it. We have put Gilbert syndrome and Crigler-Najjar syndrome as the syndromes in which problem is with glucuronyl transferase. If you really love someone, always pray. If problem has to be there, it should be Gilbert, not Crigler-Najjar. Because in Crigler there is very mild deficiency, so there is asymptomatic unconjugated hyperbilirubinemia, not a big deal. Problem really start when there is moderate deficiency. And moderate deficiency, it is autosomal dominant disorder in which there is significant reduction in what? Glucuronyl transferase activity. And these babies develop very severe unconjugated hyperbilirubinemia. Of course, they have a higher risk of developing cardiac arrest, right? How would you treat these patients? There are two things. Number one, how would you treat them? And number two, how do you cure them? Yes. How do you treat them? You give some drug which can induce the enzymes. Treatment is phenobarbital. You know, phenobarbital induces hepatic enzymes. It forces the genes to overexpress. Do you know that or not? So, we give these babies Crigler-Najjar 2 phenobarbital, which keep on forcing the hepatocytes to overexpress the genes, and glucuronyl transferase should be more, so that bilirubin handling should be at least somewhat better. And if you really want to cure, you cannot cure it short of liver transplant. We don't have any other treatment, right? Then we come to Crigler-Najjar 1. I don't know, it's really how bad condition. It's bad for mother actually, because baby never really suffers so much, because baby dies very early, sometimes in intrauterine death or just after the birth. In Crigler-Najjar 1, baby never sees first birthday. You know why? Crigler-Najjar 1, because there's severe, very, very severe deficiency, or almost in some cases absence of glucuronyl transferase activity. So unconjugated bilirubin becomes so high that it cannot be kept fused with, all of it fused with plasma protein. So all excessive bilirubin will flood into tissues including central nervous system, and such a high toxic level of this substance will damage the central nervous system so much that it won't remain compatible with the life. Is that right? Talking about that unconjugated hyperbilirubinemia is either due to overproduction and overpresentation of the unconjugated bilirubin to the liver, or it is due to reduced uptake, or it is due to impaired conjugation. In impaired conjugation, we were talking about inherited disorders and acquired disorder. In inherited disorder, we talk about Gilbert syndrome, in which there is a mild impairment, very mild impairment, no consequences on the patient's life. Then there is moderate impairment in case of Crigler-Najjar syndrome type 2. And of course, Crigler-Najjar type 1, very, very severe deficiency or almost absence of right, glucuronyl transferase. And that will end up into very high levels of unconjugated bilirubin in infant or in the newborn, and almost all cases are fatal. Then we are talking about acquired causes of impaired glucuronization function by the hepatocytes. Here I would say all the mechanisms which produce inflammation of hepatocytes. Anything which produces hepatitis, anything which produces hepatitis, that produces of course hepatocellular dysfunction. And when you have hepatitis or there is hepatocellular dysfunction, bilirubin handling will become impaired in two mechanisms. Why? When you have inflamed and dysfunctional cells, number one, they will conjugate poorly. Number two, these membranes will become defective in inflamed cells, and they will not secrete the conjugated bilirubin properly. Even inflamed cells will swell up, and when they will swell up, they will compress the biliary canaliculi, and there will be intrahepatic cholestasis. Let me repeat it again. That anything which produces hepatitis, it means that will lead to dysfunction and swelling of hepatocytes. And when hepatocytes are having impaired function, number one, they will have impaired conjugating function. Number 2, they will have impaired secretory function to the bile side. Due to that reason, in hepatocellular injury or due to hepatitis, patient develops jaundice, in which not only unconjugated bilirubin goes up, but also bilirubin which is getting conjugated may not be able to clear or pass through biliary outflow system, so that will also spill back to circulation and patient may develop conjugated hyperbilirubinemia as well. Right? So in a nutshell we can say, that in patients with hepatitis, right, there is hepatocellular dysfunction, and that will produce impaired conjugation function as well as impaired secretory functions. When both functions are impaired, that will lead to unconjugated hyperbilirubinemia as well as conjugated hyperbilirubinemia. Right? Now, what could be the causes of hepatitis? Okay. First of all, I want to know, how do you define hepatitis? Who will define hepatitis for me? Dr. Kashif. What is hepatitis? Don't give me a definition which no one knows in the world.
Simply stated as inflammation of the liver.
Okay. This is one way to say hepatitis is inflammation of the liver. Listen one thing. Attention please. For example, you take a liver biopsy. Of course, you damage few cells and they are inflamed. Is that right? Few cells are damaged and small amount of liver tissue is inflamed. Do you call hepatitis?
Diffuse inflammation.
What is the simple definition of hepatitis? Hepatitis is inflammation of liver characterized by spilling of inflammatory cells from portal tracts into liver parenchyma. Is that right? Will you remember that? Please write it down. What is hepatitis? In a simple term, hepatitis means inflammation. He is right. But when you are talking about histopathology, how we really know there is hepatitis or not? When a patient is suffering with hepatitis, actually from the portal tracts, inflammatory cells are spilling in big number to liver parenchyma. Right? So what is hepatitis? Inflammation of liver characterized by spilling of inflammatory cells, of course in acute hepatitis, neutrophil, and chronic hepatitis, lymphocytes, and acute viral also lymphocytes, right? Spillage of inflammatory cells from the portal triad to the liver parenchyma. Clear? Now, what are the causes of hepatitis? Now this is, let's suppose, this is liver lobule, and if it is injured by any mechanism, that will produce hepatitis. Right? So can you tell me some important causes of hepatitis? Yeah. Okay, viral hepatitis. We should divide it into infectious and non-infectious hepatitis. Hepatitis is infectious and non-infectious. So first of all, we should write here infectious hepatitis and hepatitis due to without infection, that is non-infectious hepatitis. Now, infectious hepatitis may be viral, is that right? And which virus you will tell me? Don't tell me just A, B, C, D, E. Tell me something more than that. Viral hepatitis. Hepatitis virus is actually hepatitis B virus. Right? Again B. What I'm talking about, look, when we say there is viral hepatitis, okay, viral hepatitis may be that some virus is damaging the liver. Some viruses predominantly involve the liver and other viruses involve the liver as well as many other tissues. The viruses which specifically involve the liver or more prominently involve the liver, they are called hepatotropic viruses. And the other viruses which may involve many organs, liver is only one of those organs, those viruses also produce hepatitis. But they are not called hepatotropic viruses. So when we talk about hepatitis, viral hepatitis, we should talk about viral hepatitis due to, yes, hepatotropic viruses and non-hepatotropic viruses. In hepatotropic viruses, of course, we specifically love to produce problem dominantly in the liver, hepatitis A, hepatitis B, hepatitis C, and delta or D, which produces problem when it is co-infected or superimposed on B infection, and then hepatitis E. we'll not go into detail of these viral hepatitis, but what I'm talking about, viral hepatitis may be due to hepatotropic viruses, which are A, B, C, delta and E. Then there are some viruses which are not hepatotropic. Can you tell me a few viruses which are not hepatotropic but can produce hepatitis? It means they, of course, they do bind with in a very strict sense, they are also hepatotropic, but along with that, they also involve many other tissues, right? So they are not specifically hepatotropic. Of course, you must be able to tell me Epstein-Barr virus, right? You must be able to tell me yellow fever virus. You must be able to tell me cytomegalovirus. This is the minimum 3 you are supposed to know when you go for your international carrier, right? So viral hepatitis, there can be bacterial hepatitis also. Can you tell me some bacteria which can produce hepatitis? Of course, one of the spirochetes, spirochetal or spirochetal. Bacteria are basically spring-shaped, coiled bacteria. Out of spirochete, there, right, which one produces hepatitis? I will give you a scenario. There is a person who is sewage worker and he has developed hepatitis with rashes and bleeding tendencies. What do you think? What could be wrong with him? There's something related with sewage worker. You know, there are in the large sewerage pipes, there are rats or their wives, mouse and male, female, all of them. Some of them pass in their urine a special type of bacteria which is called, yeah,
Leptospira icterohemorrhagica.
excellent, Leptospira icterohemorrhagica. Leptospira icterohemorrhagica, and this bacteria, when it enters in your body, not only it produces leptospiremia, it is spreading in the blood, but it also localizes in liver and produces severe hepatitis, right, and many other problems, right, especially bleeding tendencies, and many other bacteria as well. So viral hepatitis, bacterial hepatitis. Can there be protozoal hepatitis? Can there be protozoal hepatitis? Can you tell me some name of the protozoa which can produce hepatitis? Yes. Amoeba can produce hepatitis, right? When it is widespread in the liver, usually it produces a localized abscess. Any other? Toxoplasma gondii, that can produce hepatitis. Toxoplasma gondii also produces severe problem in the central nervous system of AIDS patient. From where the Toxoplasma gondii come? At least you should know cats. People who are cat lovers, or they raise the cats or they keep the cats, they may get Toxoplasma gondii. Under what circumstances you should not keep the cats in your home, preferably?
Any autoimmune deficiency?
No, when the family, some female in the family is pregnant. Because in pregnant females, if they get Toxoplasma gondii from the cats, they can pass it transplacentally to the baby and there's severe damage to the baby, right? So I think you must be knowing that, isn't it? You're working in gynae-op. What Toxoplasma gondii does to the baby? It is one of the torch infections, isn't it? It's the first one of the torch infection, right? It comes from the cats and many other pets also, but dominantly from the cats. What it is doing to the baby? You have no idea, but actually when baby develops transplacental acquisition of the Toxoplasma, it produces ear problem, ear development is defective, eyes development is defective, and cardiac development is defective, and many other combinations can occur as well, right? Anyway, let's come back. So we are talking about there can be viral, there can be bacterial, there can be protozoal hepatitis. Okay, let's come to the non-infectious causes of hepatitis. Can you tell me some known? First of all, toxins, chemical toxins. Can you tell me some chemical toxin which can produce severe hepatitis, even kill the person? Okay, very good. Alcohol is also, it should be considered chemical toxin when it is producing severe damage to your liver. Usually it is not classified as chemical toxin, but theoretically you are right, even though many alcohol lovers may not agree with you, right? So why don't you tell me something more dangerous and less loved? Carbon tetrachloride. Carbon tetrachloride is present in bleaching powders and other, and if you really get fumes of this, it will lead to hepatocellular failure as well as renal failure and very severe damage. Okay, don't that is related with the fungus.
Yes.
right? There's biological toxin, aflatoxin. I'm talking about chemical toxins. Okay, just in your honor, I will make here. Okay, alcohol can produce also hepatitis. Is that right? Alcohol can also produce hepatitis. Carbon tetrachloride is less common cause, but drastic cause. Alcohol is a common cause of hepatitis or chronic liver damage. And remember one thing, that in jaundice, when you are taking the history of alcohol intake, most of the people unknowingly understate their consumption. Is that right? Not only to their wives, but also to the doctors, right? Then toxins, alcohol, yes. Okay, why don't we forget here fungi? Fungi can also produce problems. Have you heard of Amanita phyllidus? This is a fungus. Mushroom, yes, mushroom, that can also produce problem, right? Then of course, alpha toxin or aflatoxin? Aflatoxin, that is also toxic to the liver. That's very good. And any other non-infectious drugs? There's so many drugs which produce hepatitis. So many drugs which may react with the liver substance and produce. Of course, you should not forget halothane, which is very notorious and less dangerous. But more dangerous is like paracetamol overdosage, right? That can produce severe hepatitis. And there's a long list. Yeah, any other cause of non-infectious hepatitis? Yeah? Autoimmune, yes. Autoimmune hepatitis. Autoimmune hepatitis is more common in males or females? I don't know. Females suffer with a lot of gynae problem as well as autoimmune diseases, but still they outlive the men. We have to sort out this mystery one day, right? Now, so toxins may be chemical toxins, or alcohol may be there, or drugs may be there, or autoimmunity may be there. What else? Yes. Tell me just one more cause of non-infectious hepatitis. Very important cause. Severe. Yes. Fill in the blanks, please. Severe hypoperfusion to the liver. When there is prolonged severe hypoperfusion to the liver, prolonged ischemia of the liver, in shocked patients sometimes, right? What will happen? Many cells of the liver will become necrotic, and to eat up those necrotic cells and handle those necrotic cells, inflammatory cells will spill over into liver parenchyma. So that may be responsible for hepatitis. Can you tell me some more graceful but rare causes of hepatitis? Why don't you tell me some metabolic disorders? Yeah, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. These are very graceful causes to mention, but less often seen. Of course, hemochromatosis is a bit more common. So that can also produce metabolic disorders. Metabolic disorders. There's so many of them, but at least you know 3 of them. What are those 3? Wilson's disease, especially in which you make a special type of ring, copper deposition ring in the, at the junction of sclera and the cornea at the limbus. That is called? No, that's the only thing my pronunciation is very right. Kaiser-Fleschner ring, right? Kaiser-Fleschner ring, right? You develop a brownish ring, and what type of visual problem it produces? Usually it does not. It is main importance is diagnostic. Kaiser-Fleschner ring. Wilson disease. You know, copper overloading condition in liver as well as basal ganglia. Right? That is why people develop motor dysfunction, extrapyramidal signs along with cirrhosis. Right? Okay. Wilson's disease, hemochromatosis. That also produces hepatitis and jaundice. And with that, of course, gray coloration of the skin. What is the most common? What is the common causes of death of hemochromatosis? No. What do you think? Iron is trying to go out of kidney? What are the important causes of death in patient with hemochromatosis? It is one of the most common inherited disorder in the Western world. So you must know that. One of the most common, very common. At least tell me cirrhosis, we are talking about liver. Many patients with hemochromatosis go into repeated damage due to iron loading to the hepatocytes and cirrhosis occur. Any chronic inflammation of liver will lead to cirrhosis. So tell me, many patients die of complications of cirrhosis. Many patients die another important cause of death is, yes please, in hemochromatosis patient is, we call this bronze diabetes also, isn't it?
Yes.
So what should be done? Don't tell me bronze color of skin kill the patient.
Diabetes.
Yeah, it damages the, you can say,
Pancreas.
pancreas, and diabetes, if you don't manage, person may die of complications of diabetes. But more pathetic death comes due to hemosiderin getting deposited in, yes, deposited in myocardium, and that is the major cause of death. The only treatment for that problem is cardiac transplant, right? So anyway, what I was trying to tell you, anything which produces hepatitis has a capability to produce jaundice, and that hyperbilirubinemia, partially unconjugated and partially conjugated. Let's move forward. So we have discussed the causes of unconjugated hyperbilirubinemia, which may be either overproduction of bilirubin or displacement of bilirubin from the proteins by the drugs, or it may be reduced uptake, or there may be poor conjugation. Now let's come to the causes of what?
Conjugated hyperbilirubinemia.
We talk about the causes of conjugated hyperbilirubinemia, right? And in case of causes of conjugated hyperbilirubinemia, we can divide rather into two mechanisms. 4 mechanism is here. Intrahepatic outflow problem, intrahepatic cholestasis, you write it here 5, and this is extrahepatic cholestasis. 4 and 5 have made one group, right? The group in which there is impaired conjugation is going on, either cell cannot push the conjugated material here, or conjugated material which is pushed over here, it cannot go out of liver. Is that right? So we say 4 and 5 causes previously have made them as intrahepatic cholestasis, and this was the 6th, which is now called 5th. This is extrahepatic cholestasis. Is that right? Now first we'll talk about the causes of intrahepatic cholestasis. That what's wrong with the liver, that once bilirubin is conjugated, either it cannot, somehow it cannot be properly drained through intrahepatic canalicular system, right? Now let's come to the causes of that. First of all, we'll talk about impaired canalicular transport of bilirubin, glucuronyls. Here, these transporters are not working. What could be the causes of impaired function of these transporters?
Inflammation of the particles.
This is one. Let's talk first inherited disorder and then acquired. As we reduce glucuronyl transferase activity, we divide it into what? Inherited disorder and acquired. Now we are talking about that if intrahepatic cholestasis occur, bile or you can say bilirubin cannot be pushed through, then causes which are inherited and causes which are acquired, right? Inherited causes, one is Dubin-Johnson and other is Rotter, right? One is Dubin-Johnson, another is Rotter. Rotter syndrome. The good news is that both of them are innocent. Patient does develop conjugated hyperbilirubinemia, but not a big complication to his life. So Dubin-Johnson syndrome and Rotter syndrome, both of them have a problem that there is poor conjugated bilirubin transport from the cell to the biliary canalicular system, right? But what really happens that usually this conjugated hyperbilirubinemia does not have any other marker of injury, so usually it is not toxic to the patient, right? Of course, now in this condition, Dubin-Johnson and Rotter syndrome, what is the real difference in them? These are two different conditions. Just tell me one point how they can be differentiated, of course, other than spellings. How do you differentiate them? Dubin-Johnson. Johnson was a white person or black person? There was one very famous Johnson who was black. Why the Johnson was famous?
Michael Johnson?
Michael Johnson? Anyway, there are many, you can say, black colored Johnsons. So you can remember that in case of Dubin-Johnson, liver becomes black. When you take the biopsy, liver is black because lot of metabolites which were supposed to be secreted by the hepatocyte into biliary canaliculi, they accumulated within the liver. Especially metabolites of breakdown of what is retained in the hepatocyte which produces black color. Yes, please don't tell me conjugated bilirubin, because conjugated bilirubin is poorly secreted in Dubin-Johnson as well as in rotor. But rotor liver is not black. Dubin-Johnson liver is black. What could be the reason? Because Dubin-Johnson has one more problem. Not only conjugated bilirubin cannot come out, rather plus there is another problem and another transport system which is supposed to secrete what? Metabolites of catecholamines. Right? And when the metabolites of catecholamines are retained here, they imparted black staining. Is that right? Not melanin. Now, everything black is not due to melanin, right? Anyway, so let's come back. So I was talking about these are two innocent. So if you really want to know about three innocent, one is Gilbert with unconjugated hyperbilirubinemia and Dubin-Johnson and Rotter conjugated hyperbilirubinemias. But in between is the Krigler in a jar, which is very, very bad, right? Type 2, you do survive, but very severe problem, or type 1, you simply don't survive. It's not compatible with life. Is that clear? Then we come to other causes, right? That is hepatocellular damage and toxicity. I told you hepatocellular damage should be classified as the cause of unconjugated hyperbilirubinemia, as well as hepatocellular damage should be classified as the cause of conjugated hyperbilirubinemia. Now, conjugated hyperbilirubinemia again can be caused by hepatitis. Hepatocellular damage means there is hepatitis. So, no need to go into big discussion, again come up all these things. All types of hepatitis will produce some impairment in hepatocellular function, in conjugation, and some impairment in capability of hepatocyte to secrete the bilirubin, and some impairment in the drainage system. Am I right? What will be the causes again? Infectious hepatitis, which is viral, bacterial, protozoal, fungal. Or you will talk about non-infectious hepatitis, and non-infectious hepatitis may be due to alcohol, it may be due to chemical toxins, it may be due to drugs, it may be due to ischemic deficiency, it may be due to metabolic inherited disorders. Is that right? Or prolonged ischemia, whatever. After that, there are some other special causes in which intrahepatic biliary canalicular system may not be functional, right? Can you tell me a disease in which autoimmune process specifically attacks biliary canalicular system and destroys it? These problems usually occur more commonly in females. Typically a female is in her 30s, her own 30s, and she develops severe jaundice, progressively building up conjugated hyperbilirubinemia, and she developed a lot of scoriations. Why scoriations all over her body? Itching, itching, itching. What do you think? What's wrong with that female? Don't tell me scabies. Scabies is possible with jaundice, but let's suppose in this case it's not scabies. There's a female, you should call her still young. She will be angry if you don't tell her. She's in 30s. And she has one husband and 2-3 kids. All of them need her these days. But suddenly she turned jaundice, conjugated hyperbilirubinemia. Along with that, she develops severe itching. Yeah, what could be the cause? There's an autoimmune process which is rapidly destroying biliary canalicular system. And if this process goes relentlessly, this will eliminate really virtually destroy most of the biliary canalicular system, right? Initially you will find around the biliary canalicular system a lot of lymphocytes and plasma cells, then fibrosis and elimination, right? Okay, I'll give you one more pointer to the disease. Another pointer to the disease is, if you're really going to look for what is the autoimmune process, you must check autoimmune profile including anti-mitochondrial antibodies. These females are usually positive in anti-mitochondrial antibodies. Yeah. What is this disease called?
Primary biliary
This young man knows. Primary biliary cirrhosis. What is primary biliary cirrhosis? Bile cannot be drained. So retained bile produces severe damage to the liver on chronic basis, and that chronic injury produces cirrhosis. And because it was not secondary to any stones or carcinoma, so doctor never knew what is the cause. They thought it is primary, but now we know it is autoimmune. Is that right? Primary biliary cirrhosis. So when you see a female in her 30s, right, of course younger and older females are not immune to this problem, but most commonly and classically it appears in 30s, right? And what really happens is she develops, why she was excoriating and itching all the time? You don't know. Because not only bilirubin is conjugated, bilirubin is going spilling to the blood, but along with that bile acids are also going. And bile acids are irritant to the mast cells, and low level of histamine produces severe itching. Is that right? Is that clear? So, primary biliary cirrhosis is one autoimmune process which can produce a trouble like that. Then there can be autoimmune hepatitis also. Please don't confuse primary biliary cirrhosis with autoimmune hepatitis. In autoimmune hepatitis, autoimmune processes are directed against hepatocytes. In primary biliary cirrhosis, autoimmune processes are directed against biliary canalicular system. Is that right? So what we can say that these patients may develop intrahepatic bile duct problem, and in this case there may be primary biliary cirrhosis. Can you tell me, usually autoimmune diseases are more common in females, or there are some autoimmune diseases which could be more common in males, Dr. Amtal? You don't know any disease, autoimmune disease which is more common in males? Or do you know any autoimmune disease which is more common in males? Any idea? Just use the bank of your knowledge, right? In knowledge bank, in your knowledge bank, do you think all autoimmune diseases are more common in females, or are there some autoimmune diseases which are more common in males, more common than in the males than females? Dr. Tanzila, any? Write it down. There's a basic principle. All the autoimmune diseases which are associated with MHC class 2 molecules are more common in females. I will explain this in immunology. All the autoimmune diseases which are associated with MHC class 2 are associated in more common in females, like HLA, DR group. All the diseases which are associated with HLA, DR, 4, 5, 2, they're more common in females. And right? And all the autoimmune diseases which are associated with MHC class 1 are more common in males. Thank God that those diseases are less, right? Autoimmune diseases which are associated with class 2 molecules are very common, and autoimmune diseases which are associated with class 1 molecules are less common, right? They are usually HLA-A or HLA-B or HLA-C. You have heard of diseases which are HLA-B27? For example, ankylosing spondylitis, right? That is more common in males or females?
Male.
Yeah, that is the most important cause of chronic backache in male. Females do have backache commonly, but if a male develops, young male develops chronic backache, you have to rule out, yes, ankylosing spondylitis. And another disease which is HLA-B27 associated, and in that case, biliary canalicular system is not destroyed, or rather it is filled up by the fibrotic tissue. I told you in primary biliary cirrhosis, biliary canalicular system is attacked by the autoimmune system and then it is destroyed and disappears. But in case of the condition which I am talking now, it is more common in males, and in this case, autoimmune process specially attacks the biliary drainage system and eventually produces chronic inflammation, and all the system become fibrotic. Of course, when it becomes fibrotic, it cannot drain the things well. We call it sclerosing cholangitis. Have you heard of it? Sclerosing cholangitis, which is HLA-B27 associated, more common in males. Of course, it would be the cause of jaundice as well, right? There is a GAT condition with which sclerosing cholangitis is associated. What is that GAT condition? Yeah.
Ulcerative.
Excellent. I think you have it. Ulcerative colitis. Yes, he knows a lot about ulcerative colitis. He has the knowledge about that. Now, so what we are talking about, that there can be, okay, another cause of biliary, immune system specially attack the biliary drainage system. I told you in young females, immune system may attack the biliary system and destroy it. Primary biliary cirrhosis. In young men, immune system may attack the biliary drainage system and make it fibrotic. That is called sclerosing cholangitis. And then we can talk about another immunological process in which immune system attack the biliary system. Okay, I will give you a condition. You have to tell me the name of the condition. There is a patient who received a transplant. After receiving a particular tissue transplant, within few days, patient developed rashes, bloody diarrhea, and obstructive jaundice. This triangle you must know. Patient who received a graft. And what did he develop? Rashes, bloody diarrhea with obstructive jaundice. What is that condition, Mr. Kashif? The transplanted tissue has attacked the host. This is called graft versus host reaction. When you transplant immunocompetent tissue like bone marrow transplant, when you transplant immunocompetent tissue to a immunosuppressed recipient, when you transplant immunocompetent tissue to the immunosuppressed recipient, immunocompetent tissue may attack skin of the person, mucosa of the GIT, and biliary canalicular system. This is a very classical triangle of graft versus host attack, which is called, yes, patient develop rashes, bloody diarrhea, and obstructive jaundice. Is that right? So of course that will also become a cause of what? Cause of jaundice. Okay, please tell me some drug, at least one drug, which can reduce the bile flow. Now this is the time to be impressed. Do you know one single drug group which can reduce the... Okay, I will give you a hint. Similar mechanism is involved, gynae people know it a lot. Similar mechanism is involved in pregnancy-related cholestasis. You know, there is pregnancy-related cholestasis, something like that. What is the mechanism? Okay, look at this young man and his IQ. He is saying if there is pregnancy-related cholestasis which occur at the advanced stage of pregnancy, is contraceptive pills. I think you don't know what is the function of contraceptive pills. They are not sweeteners in the mouth. You are thinking about what? The lady who is not pregnant. Let's come back to the lecture now. Right? Yes. What is the reason? Anyone who want to tell me? High level of estrogen. And that young boy was not very wrong. When female have very high level of estrogen, now they know that sometimes estrogen levels, if they become very high, they disturb the biliary drainage system. Right? In the same way, if female is not pregnant and taking oral contraceptives, again estrogen level is high, that can also produce cholestasis. So if I say which drug can produce cholestasis, please tell me. Oral contraceptive, but not in a female who is pregnant. Right? Then we can come to extrahepatic biliary obstruction. Right? Extrahepatic biliary obstruction. That's the easiest part of the lecture, which I love to talk about. What can be wrong with this system from here up to here? It's so simple. First of all, gallstones. Gallstones can produce obstructive jaundice. Usually it is fluctuating, right? Associated with upper quadrant pain, gallstones. Then there can be malignancies, yes. Malignancy of common bile duct, a malignancy of the head of the pancreas, a malignancy of ampulla of Vater. A malignancy of, so there can be malignancies, again, there may be common bile duct malignancy, malignancy of the head of the pancreas, or malignancy of ampulla of Vater. Is that right? Then there can be strictures. What are strictures and atrasias and how do they differ from each other? Common bile duct stricture, have you heard of this term? Or common bile duct atrasias. In atrasias, there is a congenital defect and common bile duct is not developed properly and it cannot drain well. Stricture is usually acquired problem. For example, you have produced a cut in common bile duct, removed a stone, and later on a stenotic fibrotic band is formed there. Right? So what could be the causes? There may be stones, there may be cancers, there may be atrasias, there may be strictures, there may be choledochal cyst. Right? There may be a cyst from this area developing and then pressing this. Right? Choledochal cyst. And of course, do you know some flukes which love to accumulate into drainage system? You don't know any flukes. You know what is fluke? What is fluke? Please don't tell me cystosoma. Cystosoma involves the liver but does not produce this problem here. Yeah? Or is it cystosoma? I don't know. Something you should tell. I've told you so many things. There's one fluke, parasite, which involves the liver. And then it produces sometimes obstructive jaundice. How many flukes names you know?
Just one.
You know only one. Okay, that's good. I also know only one. Right? I'm happy to see you. So I know others also, but I'm not willing to share my knowledge right now with you. Right? So anyway, so some flukes, liver flukes, they can produce trouble here. Right? One of that fluke is also related, okay, let me tell you, one of those fluke is also related with causes of malignancy in the liver. Yeah. Oh no, you are going for far off places. Okay, you tell me tomorrow the name of that. Right? Okay, now we come. Okay, there's another very funny type of, I should say, worm. It's really like worm. There's a worm which may be present in your GIT, and sometimes, I don't know, somehow it navigates its tip into sphincter of OD, and sphincter of OD become tight around it, and then person develops what? Obstructive jaundice. You just tell me the name of that parasite. That's a round. Yes, she knows it. Ascaris lumbricoides. How you know that? You read it somewhere or heard it? Okay, so she has read it at least about this thing, that there is a worm called here Ascaris lumbricoides, which is present in GIT, and sometimes it navigates its one end into ample of water, and then it irritates that area, and what will come? Yeah, sphincter of OD will become tightened around it, and there will be obstructive jaundice. Is that right? Of course, to diagnose this, you don't need to do ERCP. Fine? Talking about that, if you have, let's suppose you are running a center for the patients of jaundice, and many patients turn up to you. Now, just diagnosing jaundice is no diagnosis, right? It is just a state, and you have to find what is the underlying cause, what is the underlying mechanism, right? It's quite possible one person has jaundice due to mild hemolysis, another person has jaundice due to cancer, right? So, as a good doctor, you must know that you must be able to differentiate the people who have jaundice due to hemolysis, or people have jaundice due to decreased uptake of bilirubin, or who have jaundice due to impaired conjugation, or the patient who have jaundice due to intrahepatic cholestasis, or the patients who have jaundice due to extrahepatic cholestasis. Is that right? So let's talk about this thing. Basically, there are three things which are important in regard to this thing. Number one, that in these patients, of course, you have to have some points from history. You have to pick up some points from physical examination. And in these patients, of course, very important is your laboratory work, lab work. Is that right? Right, laboratory results in which you have to talk about. So this is going to tell you about the diagnosis of a jaundice person. Right? Now, when we talk about the diagnosis of jaundice, let's do a little bit practice. First of all, suppose we talk about a person who has hemolysis, right? What will be the findings in him? Different type of indicators or pointers which will point towards the diagnosis. This person has hemolysis or he has jaundice due to excessive hemolysis, right? What will be the finding? Number one, in a patient who has hemolysis, what will be the real finding? First of all, we have to determine, is there any evidence of hemolysis or not? Is there evidence of hemolysis or not? If someone has severe hemolysis, then naturally his hemoglobin may go down, especially if bone marrow cannot compensate that loss of RBCs. Usually what happens, if someone has hemolysis and if bone marrow is very, very effective in erythropoiesis, it tries its best to compensate, But let's suppose we have a patient who has severe hemolysis. Is that right? And due to severe hemolysis, what really happens that bone marrow has increased its erythropoietic activity, but still it cannot cope up or compensate for all the rapid losses, right? So his hemoglobin level will be, yes, hemoglobin level will be down in this person, number one. This is evidence of that RBCs are being destroyed or there's something wrong with the hemoglobin. Number two, in these patients who have hemolysis, right, naturally then we can talk about there are two types of hemolysis. Excessive hemolysis may be occurring within the macrophages, or hemolysis may be occurring within the circulation. When hemolysis is occurring, excessive RBCs destruction within the macrophages, we call it extravascular hemolysis. We call it extravascular hemolysis. And if RBCs break down within the circulation, then what we call it? Intravascular hemolysis. Is that right? So another thing which is there, that hemoglobin is low, and if there is splenomegaly, what do you think? Splenomegaly points to? That points to extravascular hemolysis, right? Opposite to that, if, right, this is a feature of extravascular hemolysis, but if there is intravascular hemolysis, can you give me an example of intravascular hemolysis? Autoimmune hemolysis may be vascular or extravascular. For example, in some autoimmune diseases, autoantibodies are, you can say, coating the RBCs, and these RBCs, which are IgG coated, they are trapped in the spleen, and then macrophage take them up, then it will become an example of extravascular hemolysis. But in some cases, like ABO incompatibility, of course, RBCs may undergo massive destruction within the circulation. That is an example of intravascular hemolysis. And when you have intravascular hemolysis, what will be the feature there? Number one, you will have hemoglobinemia, free hemoglobin in the blood. We call it hemoglobinemia. Number two, when free hemoglobin is released in blood, normally hemoglobin is not present in free form in the blood. Hemoglobin is packed within RBCs. Free hemoglobin is present in the blood, right? Then naturally what will happen? It will bind with certain proteins. The protein which is released by the liver to bind with the free hemoglobin, which is a toxic molecule, right? That protein is called heptoglobin. What is the name of that protein? Heptoglobin. So what really happens in these patients who have intravascular hemolysis? That number one, there will be hemoglobinemia. Number two, heptoglobin level, free heptoglobin level will be down. Heptoglobin is a protein which is released by the liver, and usually it is present in circulation. The main function of the heptoglobin is, if there is, whenever there is intravascular hemolysis, it will bind the hemoglobin molecules. And naturally when heptoglobin becomes loaded with the hemoglobin molecule, free heptoglobin levels go down. So whenever your blood free heptoglobin levels are down, it means there is intravascular hemolysis. Then if intravascular hemolysis may be acute or may be chronic, it may be acute or it may be chronic. There are many ways to differentiate them. One of the way to differentiate them is that if there is acute intravascular hemolysis, then naturally when RBCs will break down, what will happen? Hemoglobin molecules will come out. Hemoglobin is a tetramer, right? But it breaks down into free form into dimers, and these dimers can easily, go into filtrate, and they are very small. So as these are passing down, they will make, number one, these dimers may be taken up by proximal convoluted tubular cells, right? And if proximal convoluted tubular cells, if they take up this hemoglobin, there may be acute tubular necrosis because it's toxic to these cells. There may be acute tubular necrosis because these molecules may be toxic to proximal convoluted tubular cells. This is number one. Number two, what really happens that if there's a lot of hemoglobin coming down, then there may be, there will be hemoglobin urea. Excellent. So acute hemolysis may lead to, of course, clinically it may lead to acute tubular necrosis, and on investigation you may find hemoglobin urea. And another thing, This is acute hemolysis. But if there is chronic hemolysis, there is chronic intravascular hemolysis, right? If there is chronically hemolysis is occurring within the blood vessel, what will happen? Of course, other things are same. Hemoglobinemia, reduced heptoglobin level. With that, there will be hemoglobinuria. But listen, hemoglobinuria will be also there. Hemoglobinuria. But there will be one special feature. What is that? That if there is chronic intravascular hemolysis and proximal convoluted tubular cells are chronically taking up the hemoglobin, then they will develop the capacity to to synthesize apoferritin and fuse the apoferritin with the iron released from hemoglobin. In this way, these cells develop a capacity to synthesize ferritin and polymerize the ferritin to make hemosiderin. So whenever someone has chronic hemolysis, he will develop a lot of hemosiderin formation within the proximal convoluted tubular cells, and then these cells which are loaded with hemosiderin may shed into tube and then they appear into urine, and we say that there is hemosiderin-uria. Excellent. There is hemosiderin-uria. In acute cases, again, let's compare first of all that hemolysis may be within the circulation or within the macrophages. If hemolysis is within the macrophage, we call it extravascular hemolysis. If it is within the circulation, we call it intravascular hemolysis. The major feature of extravascular hemolysis is splenomegaly. In case of intravascular hemolysis, what really happens, number one, free hemoglobin is present in the blood. Number two, heptoglobin level will go down. Along with that, if it is acute case, there may be feature of acute tubular necrosis and hemoglobinuria. Even there may be cast, hemoglobin cast, right? But if this is chronic intravascular hemolysis, patient may develop not only hemoglobinuria, but with that patient may have hemosiderin-uria as well, right? Now, in this particular patient, let's suppose person who has hemolysis. Number one, in hemolysis, what happens? Hemoglobin number go down. Number two, RBC count goes down. Number three, in these patients, what really happens? Unconjugated bilirubin will go. RBCs are breaking down now. So total bilirubin will go up. First of all, total bilirubin will go up, and out of the total bilirubin, which will go really up? Unconjugated bilirubin will go up, and conjugated bilirubin will be normal. Is that right? Total bilirubin, right? They have high, and usually this unconjugated hyperbilirubinemia, in case of if your liver is functioning well, then unconjugated hyperbilirubinemia usually does not exceed above the levels of 5 to 6 milligram per day. Again, let me repeat it. If there is excessive hemolysis, right, but if liver is functioning well, hepatobiliary system is functioning well, then usually this type of hemolysis, which is resulting due to unconjugated hyperbilirubinemia, this usually does not exceed the levels of 5 to 6 milligram per dl. It means it is almost always mild jaundice. But if someone has under these circumstances having severe hemolysis, along with that, if hemoglobin unconjugated bilirubin level has gone above 6 milligrams per dl, you must think of probably there is something wrong with the liver as well. Is that clear? Now, bilirubin is high. Then these patients have more problems. What will happen? That there may be features of that bone marrow is trying to compensate. For example, reticulocyte count may be high. Retic count is high. It means this is a feature of bone marrow compensation. And when bone marrow is rapidly producing RBCs, the fresh RBCs which are released in hurry, they're slightly larger and slightly bluish tinge. So when they're slightly larger, we say there may be mild macrocytosis. And if RBCs are having unusually blue shade, we call it polychromasia. polychromasia. So macrocytosis and polychromasia occurs along with high retic count when bone marrow is trying to compensate for the RBCs which are rapidly being destroyed, right? So we have seen a person who has low hemoglobin, low RBC count, total bilirubin has gone up, dominantly unconjugated bilirubin has gone up. With that, if patient has hemoglobinemia with low heptoglobin, is that right? Hemoglobinuria, right? It is showing which type of hemolysis? Acute hemolysis, and it is also showing that bone marrow is trying to compensate. The reticulocyte count is going up, macrocytosis, slight macrocytosis, slight polychromasia is present as well. Is that clear? Now, in this particular patient, there will be no evidence of liver damage. There will be no evidence of liver damage if person's hepatobiliary system is perfectly okay. For example, you know, whenever hepatocytes are injured, listen carefully, whenever hepatocytes are injured, hepatocytes are very rich in a special group of enzymes. What is the name of these enzymes? These are transferases or transaminases, right? One is AST. AST stands for aspartate transferases or aminotransferases, and other group is, yes, ALT, alanine transferases or transaminases. Some people call them transferases, some people call them transaminases. Now in this diagram you must remember AST and ALT are present in the hepatocytes. Because these are present within the hepatocytes, so we also call them hepatocellular enzymes. Actually these enzymes are marker of hepatocellular injury. These enzymes are markers of hepatocellular injury. What is really meant by that these enzymes are the marker of hepatocellular injury, it means that whenever hepatocytes are injured, whenever hepatocytes are heavily injured, these AST and ALT, they will spill into circulation. AST and ALT. Out of them, remember, ALT, L for liver. It means it is more specific for liver diseases. AST is not as specific for the liver diseases. So whenever there is significant acute hepatocellular damage, then hepatocellular enzyme will spill into you can say circulation, and we say that serum transaminases or AST, ALT level has gone up. Here it is very important to understand that if there is acute hepatocellular necrosis, then AST level, then ALT levels are usually above the, yes, they have gone so high that usually they are more than 10 times the normal value. Again, let me tell you, if you find AST and ALT levels in a patient more than the 10 times value of the normal values, right, you must think in terms of acute hepatocellular necrosis. For example, it may occur in viral hepatitis, which is really severe one, right? So this was one point which is very important. So we can say that rising AST, ALT, especially when it is more than 10 times, it points towards the acute hepatocellular injury, right? Another thing which is important here, you see there are some other enzymes which are present over here. These are called alkaline phosphatases. These are present on the canalicular side of the hepatocyte membrane or in the biliary canaliculi. Right. When there is obstruction to, whenever there is obstruction to bile outflow, bile salts will accumulate and they will interact with these alkaline phosphatases, and these alkaline phosphatases will get detached and they will also go to circulation. Right. So it means alkaline phosphatases especially regurgitate to circulation from biliary canalicular system when the biliary outflow is blocked. Because whenever there is biliary outflow blocked, cause may be mechanism number 4 or mechanism number 5. Right? There is intrahepatic or extrahepatic cholestasis. Whenever intrahepatic or extrahepatic cholestasis is present, what really happens, these alkaline phosphatases, right, they are, you can say, acted upon by the bile salts, and they get detached and from these areas, membranes, and they spill into circulation. Even these membranes increase the synthesis of alkaline phosphatase. Usually with alkaline phosphatase, there is also another enzyme which is normally secreted by liver cell. This is called gamma glutamyl transpeptidases. Gamma glutamyl transpeptidases. So gamma glutamyl transpeptidases, another enzyme which is released by this is 5-nucleotidases. Nucleotidases. Now look, if there is cholestasis, if there is obstructive jaundice, what really happens? Not only alkaline phosphatase will go to the blood, even gamma glutamyl transferase will also spill to the circulation. Even 5-nucleotidases, nucleopeptidases, again let me repeat it. First was, what was this? Alkaline phosphatase. So whenever there is obstructive jaundice, so there is any degree of cholestasis, alkaline phosphatase will spill to the circulation. Number 2, after that what will spill? Gamma glutamyl transpeptidases, and along with that even 5-nucleotidases may also spill into circulation. It means these three, serum alkaline phosphatase, along with that, yes, what was the second enzyme? Gamma glutamyl transpeptidase, along with that 5-nucleotidase. These three are the markers of hepatobiliary obstruction, markers of biliary canalicular problem, right? Markers of canalicular injury, canalicular obstructive problem, obstructive problems. Now we can see, if someone has injury to the liver cell, what will spill into circulation? AST, ALT, transaminases. And if someone has injury to biliary canalicular system, what will spill into circulation? Alkaline phosphatases, gamma glutamyl transferases, and along with that there may be 5-nucleotidases. Is that clear? Having said all of this, I would like to introduce one more concept, that alkaline phosphatase enzyme is released by other tissues as well. Alkaline phosphatase can be released by the liver. The sources of alkaline phosphatases may be liver, or it may be bone, or it may be GIT, or alkaline phosphatase source may be, it may be placenta. Is that right? Now, so serum alkaline phosphatase may go up when there is obstructive or infiltrative diseases of liver, or when there are bone turnover is very fast, or postprandially after the food, or from the placenta. But all these enzymes which spill into circulation, they are different isotypes. They can be differentiated from the electrophoresis. These alkaline phosphatases which come from different sources, right? These can be electrophoretically separated from each other. Due to that reason, it's very important to know that if a person has raised serum alkaline phosphatase, what is the source? One of the simple way to know that source is liver or not, that if only serum alkaline phosphatase goes up, but GGT and 5-nucleotidases does not go up, it means probably the source is other than liver. But if someone has raised serum alkaline phosphatases along with GGT, along with 5-nucleotidases, of course, this must be coming from mainly from liver, right? Another point which I want to specify about the GGT. I told you GGT level goes up whenever there is some degree of obstruction or canalicular damage. Whenever there is biliary canalicular damage, GGT levels in the blood go up. In another condition also, one condition is when there is biliary canalicular injury, Another reason of raised gamma glutamyl transferase is alcohol intake. The people who take a lot of alcohol, right, in their liver, gamma glutamyl transferases are induced, right? Alcohol intake increases the concentration of and production of gamma glutamyl transferases, and then gamma glutamyl transferases appears into circulation. Now listen, if you end up with a patient who has a lot of gamma glutamyl transferase but not other liver markers, it means he is taking alcohol, right, or some other liver drug which is enzyme inducer. Or if someone has gamma glutamyl transferase along with other enzymes as well, it means gamma glutamyl transferase has gone up due to obstructive reasons or canalicular injury reason. Is that right? After what, in a nutshell, what we can say, that marker of hepatocellular injury is, yeah, AST, ALT. Out of that, ALT is more specific because AST is released by other tissues, not only from the liver. And marker of canalicular injury is mainly serum alkaline phosphatase, but along with that, there is serum level of gamma glutamyl transferase and 5 gamma glutamyl transpeptidase and 5 nucleotide levels also go up. Is that right? Then another thing which I want to introduce here, that if your liver has lost its synthetic functions, if liver has lost its synthetic function for a short time, right, it will not produce, you can say, yeah, what it will not produce? Coagulation factors, and prothrombin time will be prolonged. So prolonged prothrombin time is a marker of synthetic failure of liver, and if your liver function, synthetic function is fluctuating rapidly, prothrombin time in the patient will also fluctuate. But remember, prothrombin time depends on vitamin K dependent factors. And if you have obstructive jaundice, it means bile acids and salts are not going to GIT. It is quite possible that fat is not getting digested and you are not getting back. Vitamin K is not being absorbed because it is lipid soluble. And if vitamin K is not being absorbed, simply reduced supply of vitamin K to liver can also lead to prolonged prothrombin time. So if a patient has liver disease, you are not sure that prothrombin time is prolonged either due to synthetic failure of liver cell or it is due to obstructive problem. Very easy way to rule out. What you do? That you inject the person with vitamin K. You inject the person with vitamin K and wait for 24 hours and again check the prothrombin time. If it is normalized, then it was due to deficiency of vitamin K, right? And if it is yet still prolonged, it means synthetic functions of the liver have gone down, right? Another point which I want to highlight at this very moment is that coagulation factors have a short half-life. Due to that reason, whenever liver function is fluctuating hour by hour or day by day, prothrombin time also fluctuate along with that. Then another marker of liver synthetic capability is serum albumin. But serum albumin proteins have very long half-life, about 20 to 25 days is the half-life of serum albumin. It means if my liver stop working today, if my liver stop working today, of course, within 72 hours, my prothrombin time will be prolonged, but my serum albumin level will not go down. So if someone has really low serum albumin due to reduced synthetic function of the liver should be having problem acute or chronic? Chronic. Is that right? So we can say short-term marker of synthetic capability of liver. Short-term marker of, yes, synthetic capability of hepatocytes. What is that? Prothrombin time, once you have ruled out the vitamin K deficiency. And long term, yes, long term, what is that? Marker of synthetic capabilities of hepatocyte is serum albumin level. Is that clear? Now let's recap. We have one patient, he has severe hepatocellular injury. What markers will rise in the blood? AST? ALT. We have another patient who has severe obstruction to the biliary system. What main markers will go up?
Serum alkaline phosphatase.
Along with its friends like 5-nucleotidase and gamma glutamyl transpeptidase. Is that right? And if someone has a hepatocyte dysfunction and this synthetic ability of hepatocyte is reduced for a short time, what will really prolong?
Increased
Prothrombin time. If someone has his synthetic capability of hepatocyte significantly reduced for many months, he will have prolonged prothrombin time? Yes. Along with that, he will also have hypoalbuminemia. He will have hypoalbuminemia. Is that right? Now about the liver, you should know 4 things very clearly. Number 1, AST, ALT is a marker of hepatocellular injury. they should be considered significant when their levels are more than 10 times of their normal upper values. Number one. Number two, if AST level is double than the ALT and both are raised, this is considered a marker of alcoholic injury to the liver. Write it down. When AST level has gone, AST, ALT both are elevated, but AST level is double or more than the ALT level, it should be considered alcohol mediated injury to the liver, right? So whenever you damage the liver cell, what spills out? Serum transaminases, AST, ALT. And if biliary obstruction occur, what spills out? Alkaline phosphatase and its friends, GGT and 5-nucleotidases. And whenever there's short-term, only short-term synthetic failure of the hepatocytes, what is that? Prolonged prothrombin time. Once you have ruled out vitamin K deficiency. And if someone has prolonged synthetic function failure of the liver, he will develop not only prolonged prothrombin time, but he will also have hyperbilirubinemia. That is why low albumin is considered a bad prognostic indicator of cirrhotic patients. It is considered a bad prognostic indicator of cirrhotic patient. Now, having said all of this, let's come back. Patient who has just hemolysis, but he does not have, you can say, yes, he does not have hepatocellular injury, serum transaminases will be, serum transaminases mean AST and ALT will be normal. Then, what about markers of hepatobiliary injury? Yes, serum alkaline phosphatase will be normal, GGT will be normal, 5-nucleotidase will be normal, right? But the total amount of bilirubin which is loaded to his liver is normal or more than normal? So when it is conjugating more than normal amount of bilirubin, it means that more bilirubin is going, conjugated bilirubin is going to the urine. More conjugated bilirubin is going to the, to the GIT. More conjugated bilirubin is going to the GIT. So production of stercobilinogen is more. So stool may become dark color, and even urobilinogen production is also increased, and urinary urobilin levels also go up. Is that clear? Urinary urobilinogen also goes up. But because the bilirubin which is raised is unconjugated bilirubin. Which bilirubin is raised? Unconjugated bilirubin. And because this bilirubin is plasma protein bound, so can it spill into urine? No. So it means there is no choljuria. Choljuria means bilirubin coming into urine. So this type of problem is called acoljuric jaundice as well. This type of jaundice is called acoljuric jaundice as well. Acoljuric jaundice as well. Is it clear? Right? Now, again let's come back to our first group of patient. What was wrong with him? There is evidence of hemolysis, right? Hemoglobin is going down, RBC count is down, total bilirubin is high. Dominantly it is unconjugated bilirubin. Bone marrow is compensating. For example, reticulocyte count is high, slight macrocytosis is seen, polychromasia is seen. No evidence of hepatocellular injury, AST, ALT normal, no evidence of biliary canalicular obstruction because alkaline phosphatase, gamma glutamyl transferase and 5-nucleotidases are normal. Prothrombin time is, why it is prolonged? Prothrombin time is normal. Even serum albumin level is normal. Serum albumin is also normal. Serum albumin is also normal, right? Now, with that, urinary bilirubin is absent. Urinary bilirubin, because unconjugated bilirubin does not appear into urine because it is complex with plasma proteins. So urinary bilirubin is absent. That is why we call it acoljuric jaundice. Jaundice is there, but bilirubin is not appearing into urine. But urobilinogen is bilinogen is more than normal. Is that clear? So this is a case, we can say a sort of prehepatic jaundice. Prehepatic jaundice in which liver function tests are absolutely normal except that unconjugated hyperbilirubinemia was there, but that was due to excessive production of bilirubin, unconjugated bilirubin due to hemolysis. Now we go to another patient. Let's go to the extreme. After having discussed about case number 1, now we go to the case number 4 and 5. Is that right? We are going to now discuss a patient who has obstructive jaundice, right? Or if you really want, we can go to case number 3. What do you think? It is very easy. Case number 2 is reduced uptake. You can understand no features of hemolysis, no features of hepatobiliary injury, simply unconjugated bilirubin is high, right? Case number 3. Case number 3 is the patient who has severe hepatocellular injury. Dominant injuries to hepatocellular area with some degree of intrahepatic cholestasis. So what will happen in case number 3? This case will be a typical case of acute viral hepatitis, right? Now when we talk about this case, that in this case either some drug or autoantibodies or you can say some toxin has damaged the hepatocytes significantly, right? Then what really happens? Number 1, what will happen to total bilirubin? This is case number 2. This was your case number 1. Case number 2, yes. For example, he has severe viral hepatitis, or due to any reason he has severe hepatocellular injury. Number 1, no features of hemolysis, features of excessive hemolysis. I must say, what hemolysis? Yes, excessive hemolysis. Another thing, in this patient, of course, no features of increased erythropoiesis. For example, there is no increased retic count of macrocytosis or polychromasia. Is that right? But when you do liver function test, you find total bilirubin is increased. Out of this, unconjugated bilirubin is mildly increased, but conjugated bilirubin is more increased. But the real marker of hepatocellular injury is level of aminotransferases. So what you really find, there is a very high level of AST, aspartate transferases, and ALT, alanine transferases. They are very, very high. So this point towards the real diagnosis that there is something wrong with the hepatocellular system. With that, if there is too much damage to the hepatocyte but short term, then prothrombin time may be prolonged. And if unfortunately hepatocellular injury is for very long time and hepatocyte mass has gone too much down, right? And if hepatocyte count, cell count is very much down and mass is very much down, and then what really happens? Even albumin level will come down. But in acute hepatitis, albumin levels remain normal. Is that right? Then we can say that in these patients, the features of biliary obstruction are not there. There is slight increase in serum alkaline phosphatase is slightly increased. Gamma glutamyl transferase is slightly increased. Yeah, what was that third? 5-nucleotidase is slightly increased. So there is a heavy increase in AST, ALT and mild to moderate increase in canalicular enzymes. So we can say primary target of the injury is hepatocytes, not the biliary canaliculi. Biliary canaliculi may be suffering secondary to hepatocellular injury due to dysfunction of this face of the hepatocyte or due to swelling of the hepatocyte compressing the biliary canaliculi. Then in these patients, what really happens? That about urobilinogen maybe, urobilinogen may be normal or decreased or slightly decreased, but it is usually present if there is not full scale cholestasis, right? So again, when you come to the group number 1 and 2, you find that markers of liver cell injury are normal and markers of canalicular injury are normal. But when you come to the case number 3, right, what really happens, that markers of hepatocellular injury are very high, 10 times the normal value, and there is mild to moderate elevation and markers of canalicular injury. But we come to the case number 4 was what? Obstructive jaundice, especially intrahepatic cholestasis. Right. First, I will talk about that intrahepatic or extrahepatic cholestasis. What are the findings which are present in biliary obstruction? Then I will tell you how to differentiate. Basically, problem is intrahepatic or extrahepatic. First of all, it's a very simple thing. When a patient comes and you want to know, is it obstructive jaundice or not? What is the simplest test? Who will tell me? If a patient comes, patient is jaundiced. If your senior says, please confirm, is it obstructive or not? What is the immediate test you can do in 10 minutes in the ward? If patient is cooperative enough, to provide few drops of urine, you just dipstick and see. If urobilinogen is absent, it is cholestasis. It is obstruction. Because if there is severe obstruction, intrahepatic or extrahepatic, it means nothing is going to GIT to be converted into urobilinogen. So the simplest and very, you can say, rapid determinant of what? Of obstructive jaundice is that simply on dipsticks you check the patient's urine, and what will be the marker there? If it is obstructive jaundice, urobilinogen will be absent, and if urobilinogen is there, obstructive jaundice is ruled out. Is that right? Then obstructive jaundice is ruled out. Now let's talk about obstructive jaundice and its related parameters. What will be the features of obstructive jaundice? In case of obstructive jaundice, number 1, total bilirubin will be, high. Is that right? Out of that, unconjugated bilirubin may be slightly high, but conjugated bilirubin will be very, very high. Is that right? Number 2. In these patients, markers of hepatocellular injury, AST and ALT will be slightly high, right? But markers of canalicular injury, that is serum alkaline phosphatase, gamma glutamyl transferase, 5 transpeptidase, 5 nucleotide days, all of them will be strongly elevated. So you see, in case number 3 and 4 and 5, in all these cases, there may be elevation of hepatocellular enzyme as well as canalicular enzyme. But if hepatocellular enzymes are very high or canalicular enzymes are slightly high, it must be hepatocellular injury. Or if canalicular enzymes are very high and hepatocellular are mild to moderately high, it must be dominantly obstructive problem, cholestatic. Is that right? Another way to look this situation is that if there is obstructive problem, then what really happens? In early course of the disease, canalicular markers go up. And later on, if obstruction remains for a long time, then cell damage start and transaminases also appear. So if a patient of jaundice comes and you repeat his liver function test over a few days or weeks, you find initially alkaline phosphatase and its friends go up, and later on, gradually transaminases go up. Problem started as obstruction. But if another patient comes to you and in his blood, initially there is very high level of AST, ALT, and gradually then canalicular marker like alkaline phosphatase and its friends go up, then we call this hepatocellular injury to begin with, leading to cholestasis due to swelling of the blood and due to the membrane, canalicular membrane dysfunction. Is that right? Now, then in these patients, if there is full obstruction, of course, a very important thing, there is no urobilinogen in urine. But in the urine, conjugated bilirubin which goes to blood, it is water soluble. So it can appear into urine. So there will be choleuric jaundice, or there will be urinary bilirubin is present. Bilirubin is very high. Now look here again. Whenever there is obstruction, urinary you can say urobilinogen become absent, because no conjugated bilirubin is going to the GIT to be converted into urobilinogen. But conjugated bilirubin spill into circulation, and that also spills into urinary system, because conjugated bilirubin is not plasma protein bound, so it easily spills into circulation, and it is water soluble, so it appears into urine. So we can say urine will turn which color? Dark color. Urine will turn due to presence of the you can say conjugated bilirubin. Urine will turn dark color. Opposite to that, what will happen to GIT? Because conjugated bilirubin is not coming to GIT. GIT is not making urobilinogen or stercobilinogen, so stool will become clay colored or light colored or pale colored, right? So dark colored urine and light colored stool with urinary absence of urobilinogen and elevation of level of bilirubin in the urine, right? It all indicates what type of obstruction is there. It only tells that there is obstruction, obstructive jaundice. It does not tell the type of obstruction. It just tells that obstruction is there. I really want to know that, again, what I've said, that urine in these patients, urine will be, yes, will be dark colored and stool will be light colored. With that, because there is cholestasis, bile acids also go to the circulation and bile salt, and they produce severe itching. So there's a lot of excoriations or itching. So when you jaundice patient with itching and dark colored urine and light colored stool, it is definitely a case of cholestasis. And usually in cholestasis, if it becomes prolonged, lot of cholesterol is retained in the body, and this cholesterol may produce special yellowish plaque under the skin. We call them xanthomas and xanthelasmas. Xanthomas. So what did we learn? That in 4 and 5 cases, when there is obstructive jaundice, most important finding is urobilinogen absent from urine and conjugated bilirubin present in urine and conjugated hyperbilirubinemia, and markers of canalicular injury appear first in the blood and in very high amount, and markers of hepatocellular injury appear late and less in amount. Am I clear? Now after having said all of this, now how do you differentiate really cases of 4 and 5? Is it intrahepatic obstruction or extrahepatic obstruction? Very easy. What will you do? Just do ultrasound. If you do the ultrasound and you find common bile duct dilated, it is extrahepatic obstruction. In this case, right, you go for ultrasound, and ultrasound can tell you if common bile duct dilated, then it is extrahepatic cholestasis. But if common bile duct is normal diameter, then it is intrahepatic obstruction. If there is intrahepatic obstruction, then bile is not going to common bile duct, so it will not be dilated. But if there is, suppose, what is here, papillary carcinoma, or there is carcinoma of the head of the pancreas, or there is a common bile duct carcinoma, or there is a gallstone, a stricture, or atresia, all these things will produce what type of problem? Dilated what? Common bile duct. Is that right? So extrahepatic biliary system, if it is dilated, you must think of extrahepatic cholestasis. If they are not dilated, we must think of intrahepatic cholestasis. The next investigation which is important, that if you find that there is extrahepatic, what is there? If there is extrahepatic cholestasis, the next investigation should be ERCP. ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. What you really do it, that you pass a catheter from here, endoscope from here, and this endoscope is going, and it is side viewing endoscope. Through this endoscope, you have taken the endoscope through the oral cavity to the esophagus, pharynx, esophagus, and then to the duodenum, through the stomach and duodenum. Then this is a mirror, you can say, which can view on the side viewing duodenoscope, we call it, and it will locate ample of water. When it will ampullate, then we bring a catheter out of it. What do we bring out of it? A catheter, and we engage the catheter into papilla of water, and then we put a radio opaque material, so it can lead to, and then we take up the X-ray, so it can show the pancreatic duct as well as it can show the common bile duct, and not only it can show the anatomy of that area, but it can show the level of obstruction as well. Is that right? We call it ERCP, endoscopic retrograde. We are going retro. This is going retrograde, endoscopic retrograde cholangiopancreatography. Endoscopic, then retrograde. It's going in retrograde fashion, right? It's pushing the dye in retrograde fashion. Cholangiopancreatography. Is that right? And another advanced form which has come here, and that is replacing the ERCP as you can say investigative tool, that is MRCP. MRCP test. What is MRCP? Magnetic resonance. Magnetic, it is something like MRI. MRI taking the information about the common bile duct and the ductal system. So we call it magnetic resonance cholangiopancreatography. These days, this investigation is replacing, wherever it is available, ERCP for its diagnostic functions, but not for its therapeutic functions. Now, we come to this patient who has common bile duct problem. What you will do with this patient who has common bile duct problem? Common bile duct is normal. It means there is problem intrahepatic. If there is intrahepatic obstruction, what type of investigation will you do? The next? Yes? What is that? PTC. What is PTC? Percutaneous transhepatic cholangiography. Percutaneous transhepatic cholangiography. What you really do in this case, that in the mid-axillary line, first you percuss out the border of liver, right? In the mid-axillary line, guided by ultrasound, you push a needle which should end up into some dilated radical of biliary collecting system, and there you inject the dye to visualize it. If all these things fail, you are left with only to do liver biopsy. You are supposed to do liver biopsy. Again, let's come back. Now I'll ask you a question. If a patient comes to you, there's a patient who comes to you, and patient is having severe itching. There's a young female, severe itching, some xanthomas, conjugated hyperbilirubinemia, right? No urobilinogen, lot of bilirubinuria, dark urine, light stool. What type of jaundice is this? Obstructive jaundice. AST, ALT are mildly raised, and alkaline phosphatase, 5-nucleotidase, and gamma glutamyl transferase are severely raised. So what is this? Obstructive jaundice. Now in this patient of obstructive jaundice, when you do ultrasound in this lady, common bile duct is not dilated. Is that right? If you do some autoimmunity profile, you find anti-mitochondrial antibodies very high. What do you think? Anti-mitochondrial antibodies are associated with primary biliary cirrhosis, autoimmune process which attack the biliary system. Is that right? Another case, patient come, and patient is very much pale and jaundice. Pale means hemoglobin is low, and icterus mean yellow color is there, right? And patient has strong history of blood transfusions previously due to, he has been receiving blood transfusions due to severe anemia. Is that right? His spleen is enlarged. Coombs test is positive against the RBCs. It means the RBCs are coated with autoantibodies. Is that right? Unconjugated bilirubin is 5.5 milligram per dl, right? With little increase in total. Urobilinogen in the urine is more than normal. Stool is dark colored. AST, ALT normal. Prothrombin time normal. Serum albumin normal. Alkaline phosphatase normal. Ultrasound shows normal ductal system and ductal anatomy. What do you think? This is extravascular hemolysis because splenomegaly was there. It was extravascular hemolysis. Now I will ask one more question. If a patient has come to you and patient has complained of, listen carefully, patient has severe anorexia, nausea, low-grade fever with upper hypochondriac pain for many days. Patient has developed jaundice in which total bilirubin is high, conjugated is also high, unconjugated is also high. There is a mild to moderate increase in alkaline phosphatase, serum alkaline phosphatase, and gamma glutamyl transferase and GGT and 5-nucleotidase, and there is very high AST/ALT. What's wrong with them? There is hepatitis, and in this patient you find that hepatitis B surface antigen is positive as well as hepatitis B E antigen is positive. What is diagnosis by now? Very clear. Acute? We cannot say is it acute or chronic. If it is less than 6 months, it must be considered acute. If it is more than 6 months, then it must be considered chronic. Is that right? Because in hepatitis, cutoff point is that evidence of liver injury is less than 6 months or more than 6 months. If it is less than 6 months, it should be considered acute. And if markers of liver injury or history is showing problem related with the liver is more than 6 months, then it is chronic. Is that clear? Okay, I will give you one more case. Patient is brought to you and patient has severe weight loss, severe anemia, severe abdominal pain, right, especially radiating backward. Patient has pale colored stool and steatorrhea, dark colored urine, no urobilinogen there, AST, ALT slightly raised, serum alkaline phosphatase very much raised, conjugated bilirubin very much raised. Now, but it is obstructive jaundice, but there are special things I have said. There is an old man in this case. There is an old man, number one. Number two, there is very significant weight loss. Number three, there is severe pain in the abdomen radiating backward. It's very good. Carcinoma of head of pancreas, cancer of head of pancreas. But if same patient having lot of occult blood appearing into fecal matter, then it is probably carcinoma of ampulla of Vater. Is that clear? Any question here? Any question? No question? Class dismissed.